Okay, so we will start now the second most important section in microbiology, that is virology. So, the world of bacteria is constant except drug resistance. There is no newer updates in bacteriology. Most of the I mean in last 10 or 15 years there is no new bacteria which have been discovered. No pandemics or threat is going on because of bacteria. Whatever is happening in last few years, pandemics, epidemics, threat, all those are due to viruses. You talk about Ebola virus in 2014, you talk about Zika virus in 2016, or you talk about H1N1 in 2009 and 2015. So, most of the viral most of the outbreaks, epidemics and pandemics in the recent years are due to viruses. So, unlike before, now you have to give equally importance to virology like bacteriology. Okay. So, with this let us now start the first chapter, that is introduction to virology. What is the difference between a bacteria and a virus? Bacteria and virus, the main difference is viruses are obligate intracellular. Viruses cannot grow on artificial medium. Bacteria, they have both DNA and RNA, whereas viruses, they have either DNA or RNA, but never both. Viruses, they say that they divide by a complex way of cell division, whereas bacteria, they divide by binary fission. Bacteria, they have ribosome, viruses, even the ribosome will be absent. So, they are the most primitive microorganism. They say that viruses are below the definition of prokaryotes. Viruses do not fit into even prokaryotes also. Okay. So, coming to the classification, as I told you, viruses are classified into DNA and RNA viruses. DNA viruses examples: 3P stands for pox, parvo and papova. 2H stands for herpes and which hepatitis? B. And AB stands for adenovirus and bacteriophage. That is all. The spectrum of DNA viruses are limited. Very few DNA viruses are there. Most of the viruses are RNA viruses. If you, the various families are there, like myxovirus, arboviruses. A myxovirus, it could be paramyxo or orthomyxo. Arboviruses, other hepatitis viruses, picorna, which includes polio, rabies, retroviruses like HIV, reoviruses like rotavirus, okay. So on. Like that, there are many other miscellaneous viruses like Ebola virus, etc. Okay. So, most of the viruses are RNA viruses. Which is the largest virus? The largest virus is a DNA virus, pox. The smallest virus is also a DNA virus. Most of the DNA virus, they have a double standard DNA, except parvo, which possesses a single standard DNA. Similarly, most of the RNA viruses are single standard. except reovirus, they have double stranded RNA. Okay, what about HIV? HIV has single stranded or double stranded? They say that HIV has 2 copies of single stranded RNA. 2 copies of single stranded RNA. Then there are some RNA viruses which have segmented RNA. Segmented RNA, example, they say that there is a code for this beta, stands for bunia, influenza, rotavirus, reovirus and arenavirus. Okay, influenza virus has got 8 segment, rotavirus has got 11 segment. Fine. Coming to the morphology of virus, viral morphology is nothing but they have a capsid which is surrounded by nucleic acid. Capsid is composed of small protein units called as capsomere, and the relationship of capsid to nucleic acid determines the symmetry of the virus. Symmetry of the virus is the nucleic acid and the capsid, how they are arranged to each other. There are 2 important symmetry, icosahedron symmetry, where the capsid forms a hexagonal shapes structure surrounding the nucleic acid, whereas there is a helical symmetry where the capsid circles like a helix surrounding the nucleic acid. Which is common? Icosahedral icosahedron symmetry is the most common variety. Except there are certain RNA viruses which are we can remember as MRF BAT, stands for Mixo, okay, Rhabdo, Filovirus and Bunia virus. These are the few exceptional viruses that have helical symmetry. They have helical symmetry, Mixo, Rhabdo, Philo and Bunia virus. And of course, pox virus has a complex symmetry, whereas most of the other viruses they have icosahedron symmetry. Okay. Certain viruses surrounding the capsid, another layer of structure will be there which is called as envelope. Not all, but some viruses will have an outer structure called as envelope. So let us discuss what is envelope. Envelope is nothing but it is a lipoproteinous structure, lipoproteinous coat. Okay, they have a protein part, they have a lipid part. They have a protein part, they have a lipid part. The outer covering is the lipid part, and the embedded structures are the protein part. This is how the envelope is designed. The protein part is of course virus coded. Like any part of the other virus, even the protein part of the envelope is virus coded, but the peculiarity is the lipid part of the envelope is derived from host cell membrane. The lipid part of the envelope is derived from host cell membrane. Okay, it is derived from host cell membrane. So which part of the virus is not virus coded? Answer is the lipid part of the envelope. Most of the viruses are enveloped, whereas few viruses which are non-enveloped. And please remember, non-enveloped viruses are more resistant to disinfection and heat. They are more resistant to disinfection and heat. So, only few viruses are non-enveloped. Among the DNA virus, the non-enveloped viruses are PAP, stands for parvo, adeno and papova. Among the RNA viruses, it is PARC, stands for polio, that is picorna, astro, rio and calci, plus even hepatitis A and E, they are also non-enveloped. Hepatitis A and E are again non-enveloped viruses. Fine. So, this is about viral morphology. Coming to viral replication, as I told you earlier, viruses, they replicate in a complex manner. Unlike bacteria which replicate by binary fission, viruses, they have a complex way of cell division which can be sequentially grouped into various steps. First step is attachment, then penetration, uncoating, then the replication stage or the biosynthesis step, then maturation and assembly, and finally you have a release. Okay. So, these are the various steps. Among these, which step decides that which virus is going to happen, going to infect which cell? Which is the step that decides which virus going to infect which cell? It is the attachment step, which is the most specific, because it involves the receptor interaction. Like example, for HIV, the GP120 of HIV binds to CD4 molecule of host cell. So, it involves the receptor interaction that decides which virus infects which cell, followed by penetration. So, first step is attachment, where the specific receptors bind to each other, followed by the virus goes inside penetration. After that, there is an uncoating step where the capsid is lysed, destroyed, and the nucleic acid is released. So, the capsid is destroyed and the nucleic acid is released. This nucleic acid then will be subjected to biosynthesis. It will replicate either in the cytoplasm or in the nucleus. Host cell will have nucleus also. So, some viruses will replicate in cytoplasm, some viruses will replicate in nucleus. So, in this context, I want to tell you into the detail. They say that most of the DNA virus, they replicate in the DNA will be replicated in nucleus, except that which is the largest DNA virus. Pox is the only exception, because it is so large that it will replicate in cytoplasm itself. Hepatitis B is again one more exception, partly nucleus, partly cytoplasm. Otherwise, most of the DNA viruses, they replicate in nucleus. The DNA is replicated in nucleus. See, replication means what? In the replication step, the biosynthesis take place. Biosynthesis means all the viral structures will be produced. All the viral structure means it is the nucleic acid as well as the capsid proteins. Proteins are translated always in cytoplasm, whereas for DNA viruses, the DNA alone is replicated in nucleus. If it is RNA virus, most of the RNA virus, the RNA is replicated in cytoplasm. Except, you know the answer, HIV. HIV goes and integrates with the host cell chromosome. So, HIV replicate in nucleus, as well as influenza virus. This also replicate in nucleus. Whereas the proteins of RNA viruses, they always replicate, the biosynthesis occur in cytoplasm. In this context, I want to tell you one thing. The single stranded RNA viruses are classified as either positive strand RNA virus or negative strand RNA virus. This classification is mainly dependent on whether the RNA has a positive polarity or a negative polarity. They say that the positive sense, most of the RNA viruses are positive sense RNA virus, except MR. MR stands for myxoviruses and rabies. They are example of negative sense RNA virus. What is the main difference between a positive sense and a negative sense is, see, they say that the positive sense RNA virus, the RNA itself acts as mRNA. The RNA itself acts as mRNA and it directly undergo translation to produce proteins. And of course, the positive sense RNA virus will also replicate to produce millions of positive sense RNA virus. Then the assembly will take place to produce the daughter viruses. This is about positive sense RNA virus. In contrast, the negative sense RNA virus, the RNA has a negative polarity. It cannot directly translate. First, it has to be converted to a positive sense mRNA first. Then the positive sense mRNA will undergo translation to produce the protein structures. Similarly, the negative sense RNA virus can replicate to produce millions of negative sense RNA virus. Then finally, the assembly takes place to produce the daughter viruses. Okay, so this particular step is extra. This is the step which is extra in negative sense RNA virus. They directly do not translate, they have to convert to a positive sense RNA virus, then only they will translate. Fine. So, this is all about viral replication. Then the last two steps are assembly and then release. Release, mostly they will release by budding or lysis, a lysis of the host cell. Either they will bud out or they will destroy the host cell and they come out. Fine. So, this is all about viral replication. Now, we will discuss about viral cultivation. Viruses can be cultured in artificial medium or not? There is no artificial medium. Viruses can grow either in animal or egg inoculation or tissue culture. Animal mice inoculation. They say that mice inoculation, which is important for arboviruses and Coxsackie virus. Coxsackie virus can be differentiated into Coxsackie A and Coxsackie B based on intracerebral inoculation into suckling mice. How to remember is Coxsackie A, you have to remember alphabetically, first F then S. When you inoculate the virus into the suckling mice intracerebrally, Coxsackie A produces flaccid paralysis, whereas B produces spastic paralysis in suckling mice. Next is egg inoculation. Egg inoculation, they say that embryonated egg has to be used, and the embryonated egg has got an embryo inside which is surrounded by a amniotic sac and a yolk sac. Upper sac is called as amniotic sac, and below it is surrounded by a yellow structure which is the yolk sac, and this further surrounded by a bigger cavity called as allantoic sac, and allantoic sac is lined by a membrane called as CAM or chorioallantoic membrane. Chorioallantoic membrane. Now the question is, which part of the virus, which part of the egg which virus will grow? This is easy to remember. They say that amniotic sac is used for the growth of influenza virus. Whereas allantoic sac is a bigger, you can have a look which is the bigger cavity, allantoic sac or amniotic sac. Allantoic sac is the much bigger cavity, hence allantoic sac is the site for preparation of viral vaccine. And which vaccine we prepare in egg? Egg derived vaccines are influenza vaccine, yellow fever 17D vaccine, and flurry vaccine of rabies. These are the three vaccines which can be prepared in allantoic sac of embryonated egg. Yolk sac, as we have discussed, it is important for chlamydia, rickettsia. Among the viruses, arboviruses, and sometimes even Haemophilus ducrei also grow in yolk sac of egg. Chorioallantoic membrane, certain viruses they produce necrotic lesion on chorioallantoic membrane. These lesions are called as pox. Pox are the lesions produced by the growth of virus on chorioallantoic membrane, and these pox lesions are produced by pox viruses like variola and vaccinia. Apart from that, even herpes simplex virus also can produce pox lesions on chorioallantoic membrane. So this is how the various viruses can grow in various part of embryonated egg. Now tissue culture. Tissue culture, it could be the whole organ culture. Example is the tracheal ring are used for coronavirus, or it could be explant culture, that is crest organ are used. Here example is adenoid explant used for the growth of adenovirus. Then cell line. Cell line means the organ is completely digested by adding various digestive enzymes like trypsin, chymotrypsin and various digestive enzymes you can add, and you can completely digest the organ, and individual cells are separated. Individual cells are separated, which are then mixed with viral growth medium, and after they are mixed with viral growth medium, they can be dispensed in tissue culture flasks. Okay, there are specialized tissue culture flasks which can be used. Okay. So, the fluid, the viral growth medium containing the individual cells, they can be packed in tissue culture flask. So, this tissue culture flask containing the individual cells with the viral growth medium is used for cultivation of the virus, and these individual cells after some time in the tissue culture flask they will form a monolayer of cells. They will form a monolayer of cell on the base of the tissue culture flask. So, when you inoculate the specimen containing the virus they can infect the individual cells and they can produce certain morphological change which is described as cytopathic effect, So, after some time the cells will die. You know that any cell line, the cells will die in some time. So, when they will die, they will be replaced by fresh cells. The old cell will go off and which will be replaced by fresh cell. So, after some time the cell line will be totally destroyed. They will not be able to revive. They will undergo natural death. So, after how many number of cell divisions the cell line will undergo senescence, depending on that you can divide the cell line into primary cell line, secondary cell line and continuous cell line. Primary cell line they can divide for 5 to 10 number of cell divisions. After that they will die. Example is monkey kidney cell line, MKC. Human amniotic cell line, and chick embryo fibroblast cell line. Chick embryo fibroblast cell line. Okay. Secondary cell line, they will divide for 10 to 50 number of divisions. Examples: human fibroblast cell line, and this human fibroblast cell line is used for the cultivation of cytomegalovirus. In contrast, the continuous cell line, they are derived from cancerous cells. So, that is why they will have haploid karyosome. And because they are derived from cancerous cells, they are immortal, that is they will have indefinite cell division. So, it is very easy to maintain the continuous cell line. They will never die, they will have an indefinite cell division. Example: there are so many continuous cell line: HeLa cell line, Hep2 cell line, okay, Viro cell line, BHK cell line, McCoy cell line. HeLa cell line is derived from human CA cervix cell line. Hep2 is human epithelioma of larynx. Viro cell line is vervet monkey kidney cell line. BHK is baby hamster kidney cell line. McCoy cell line is derived from synovial cell carcinoma. So, like that these continuous cell lines are derived from various cancerous cells, and please remember they will have a haploid karyosome and they have indefinite number of cell divisions. The question is how to detect viral growth in the cell line. Detection of virus in cell line. As I told you, virus when they infect they will produce certain morphological change which are called as cytopathic effect. Morphological change in cell line produced by viruses. For example, enterovirus will produce crenation and degeneration of cell line. Herpes, you will have ballooning and diffuse vacuolation. Adenovirus, grape like cluster. Then measles, multinucleated giant cells, MNGs, multinucleated giant cell. This also is seen in RSV, respiratory syncytial virus, multinucleated giant cell. Okay, so these are the various cytopathic effects. As SV40 virus will produce cytoplasmic vacuolation. But my question is, do all viruses produce cytopathic effect? No. Only few viruses what has been enlisted here, they only can produce cytopathic effect. Then how to know that other viruses are really there inside the cell line or not? There are some other method of detection of viral growth apart from cytopathic effect. That is, you can detect viral antigens in cell line by doing a direct immunofluorescence test. One of the antigen is heme agglutination antigen, heme agglutinating antigen. This can be example influenza. Influenza will have heme agglutinating antigen. That can be detected by heme agglutination reaction. You can also detect the viral growth by the principle of interference. Interference means the presence of one virus prevent entry of other virus. Suppose, I mean, this property is like very peculiar. They say that viruses they compete with each other. If one virus is present inside, that will not allow the entry of other virus. So this property can be exploited. Usually it is exploited to diagnose rubella virus. Rubella virus is a non-CPE virus. It does not produce any cytopathic effect. Suppose you want to know that inside the cell line rubella virus is present or not. Okay, this is one cell where the rubella virus is present inside. This is one cell where there is no rubella virus. As there is no cytopathic effect, you cannot know the virus is there inside or not. So this cell line can be challenged by a known cytopathic virus, like for example ecovirus. So whether rubella is there or not inside, you can know by challenging the cell line with a known cytopathic virus. Suppose if rubella is already there inside, it will not allow ecovirus to go. That means after adding ecovirus to the culture fluid, also the cytopathic effect will not be produced. But if rubella is not there inside, if you challenge the cell line with ecovirus, eco will go inside and that lead to a production of certain cytopathic chains. So, this is called as viral interference, which property can be exploited to know the presence of virus inside. Apart from that, the viral genes can be detected by doing a PCR. So, all these are various method of detection of viral growth inside the cell line. Okay. So, now we will discuss about viral vaccines. The viral vaccines, I will just outline the classification of the viral vaccine. The detail we will discuss under individual topic. The viral vaccines can be classified as inactivated vaccine, live attenuated vaccine, both inactivated and killed vaccine, both killed and live vaccine. Inactivated vaccine example is rabies. Rabies, both neural and non-neural, are example of inactivated vaccine. Even killed KFD vaccine is also an example of inactivated vaccine. One variety of vaccine is called a subunit vaccine. This is one more variety. Subunit vaccine means it is not the whole virus, it is only a part of the virus, is one unit of the virus is used for vaccination. Example is hepatitis B vaccine. Here only HBsAg is used for vaccination. HPV vaccine. Here only the E6, E7 protein antigens are used for vaccination. So, this is called a subunit vaccine. This kind of subunits are prepared by DNA recombination technology. Only the particular part of the virus is used and they are prepared by DNA recombination technology. Example of viruses where both killed and live vaccines are available. Influenza. Influenza has both live and killed. Polio, OPV, IPV, which is live. OPV is live, IPV is killed. Japanese encephalitis. The 1414-2 strain is live strain, whereas Nakayama vaccine and Beijing's vaccine, both these are killed vaccine. Okay. Then one more example of live and killed is hepatitis A vaccine. Both live and killed vaccines are available for hepatitis A. Yellow fever. Yellow fever, the 17D vaccine is live, whereas the outdated old darker vaccine is an example of killed vaccine. The outdated darker vaccine for yellow fever is an example of killed vaccine. Can you tell me the viruses where only live attenuated vaccines are available? The example is MMR and 2 poxes, that is measles, mumps, rubella, 2 pox, smallpox, chicken pox. Can you tell me the vaccine strains for each? Measles, the vaccine strain used as Edmonston Zagreb strain. Mumps, Jerry Line strain. Rubella is RA 27/3 strain is used. Smallpox is caused by, the agent of smallpox is variola, but the vaccine given is vaccinia. Chicken pox, the agent is varicella, and for vaccine it is the Oka strain of varicella zoster virus that is given as vaccination. Okay, so these are the various classification of viral vaccine. Okay. Inclusion bodies. are the morphological changes produced by the virus in vivo, that is inside the cells. So, the morphological changes produced inside the cell of human and animal body, these morphological changes could be either intracytoplasmic in location, or the inclusion bodies could be intranuclear in location, or could be both intracytoplasmic and intranuclear in location. Intracytoplasmic inclusion body, the most important example is rabies, where you will have Negri body. Other than that, variola virus, which produces Paston body, vaccinia virus, that produces Guarnier body, Fowlpox produces Bollinger body, and molluscum contagiosum virus, where it produces molluscum body. Intranuclear inclusion body, Cowdery has classified into Cowdery A and Cowdery B. Cowdery A, herpes, which are described as lips-loose body, and yellow fever, where it is called as Torres body. And Cowdery type B inclusion bodies are seen in adenovirus and polio. Similarly, the viruses which produce both intracytoplasmic and intranuclear inclusion bodies, they are measles and cytomegalovirus. Cytomegalovirus inclusions are described as owl's eye appearance inclusion body. Owl's eye appearance inclusion body. Okay. Then the shape of the virus, according to that, they say that most of the viruses are roughly spherical. Most of the viruses are roughly spherical, with the exception of certain viruses like pox virus, brick shaped, rabies, bullet shaped, Ebola, filamentous shape, and adenovirus, space vehicle shape. Okay. Other than that, most of the viruses are roughly spherical. So, herpes can be classified into three groups: alpha herpes, beta herpes and gamma herpes. Alpha herpes has herpes simplex virus 1, 2 and varicella zoster virus. Beta herpes has cytomegalovirus and human herpes virus 6 and 7. Gamma herpes has human herpes virus 8 as well as Epstein-Barr virus. Alpha herpes, they replicate fast and they spread fast, whereas beta and gamma herpes, both replication is slow as well as they spread from one cell to other cell again slowly, both beta and gamma herpes. Okay, so these are the basic difference, and one more difference is the site of latency. alpha herpes undergo latency in neuron, whereas beta herpes undergo latency mainly in the the cytomegalovirus undergo latency in the salivary gland, whereas HSV 6 and 7 undergo latency in T cell, whereas human herpes virus 8 and Epstein-Barr virus, they undergo latency in B cell. Okay. So, this is how the site of latency vary from each other. So, with this introduction, let us start herpes simplex virus. HSV 1 and HSV 2 can be differentiated by various way. One is where they replicate. Of course, I told you neurons. Which neuron? HSV 1 mainly undergo latency in trigeminal nerve, whereas 2 undergo latency in sacral ganglia. Usually HSV 1, the most common site will be mouth, above the waist, whereas HSV 2 in the genital region, and usually they infect below the waist. The transmission is concerned, HSV 1 is transmitted mainly by direct contact. Contact transmission is seen in HSV 1, HSV 2 mainly by sexual as well as vertical transmission. Next is the various clinical manifestations. To start with mucosal lesion, herpes simplex virus, most commonly the most common primary lesion will be pharyngitis and gingivostomatitis. Of course, most common site will be buccal mucosa, and the most common secondary lesion, that is recurrent lesion, will be herpes labialis, involvement of lips. And please remember, by definition the recurrent lesions are always less severe for herpes. The recurrent lesions are less severe for herpes. Coming to CNS manifestation, herpes can usually infect they say that it is the most common cause of acute sporadic viral encephalitis. It is the most common cause of acute sporadic viral encephalitis, and the most common site will be the temporal lobe. The meningitis produced by herpes is described as molarate meningitis. Molarate meningitis. Coming to the cutaneous manifestation, list of cutaneous conditions can be produced by herpes, which can range from febrile blister, okay, one of the agent of erythema multiforme, it can also cause herpes gladiatorum. This usually in the nurses and other paramedical worker. Nurses and other paramedical worker, it can cause another condition called as herpes whitlow. herpetic whitlow. Whitlow will be produced in the paramedical worker like nurses. Herpes gladiatorum is a condition which is seen in wrestlers. Okay, so there are various cutaneous which can be produced by herpes. One more condition is Kaposis varicilliform eruption. Both herpes and vaccinia can cause Kaposis varicilliform eruption. So all these are cutaneous manifestation. Then ocular manifestation, herpes can cause dendritic ulcer, genital. The genital ulcers are described as bilateral, painful, multiple, tiny vesicular ulcers. The herpes ulcers are described as bilateral, painful, multiple, tiny vesicular ulcers. Then where is visceral manifestation? They say that the visceral involvement is common in congenital infection. Then congenital herpes, which is the most common agent, 1 or 2. Herpes simplex 2 is a more common cause to transmit vertically, and the most common timing is during delivery. They say that during delivery the transmission is maximum, and the transmission is again maximum if mother acquired the primary infection. They say that if the mother is infected primarily with herpes, then the transmission is maximum. If the mother is previously infected and if she has IgG antibody, then the transmission is said to be negligible. Fine. So this is all about manifestations. Then the lab diagnosis. Lab diagnosis, Jank smear. Jank smear is done for diagnosis of herpes simplex. They say that it is a toluidine blue smear. Toluidine blue staining demonstrating the various cytopathic effect like multinucleated giant cell, syncytium formation, diffuse roundening and ballooning. All these are various cytopathic effect which can be seen on the Jank smear. Fine. So this is all about laboratory diagnosis. Of course, the drug of choice is acyclovir. Next we will discuss varicella zoster virus. Varicella zoster virus can produce two broad category of manifestation: chicken pox and zoster. Primary infection leads to chicken pox. This usually occur in children, but if it occurs in adult, it is more severe. Children are more commonly affected, but if it happens in adult, it is more severe. In contrast, zoster is reactivation of the latent virus. Reactivation of latent virus, and the latency, the site of latency is, they say that the ophthalmic branch of trigeminal nerve. This is the site of latency, ophthalmic branch of trigeminal nerve. Fine. So, they say that chicken pox of course is a disease of childhood. Here they say that the incubation period is 2 to 3 weeks and the patient is infectious from -2 to +5 days of onset of rash until the rashes are crusted, until the crusted lesions are produced. So, which is usually -5 days. Okay, so this is the period of communicability of chicken pox, and if it occurs in adult, as I told, it is more severe with all sort of complications. Among the complications, the most common complication is secondary bacterial infection. Most common CNS complication is, they say that encephalitis and cerebellar ataxia. Cerebellar ataxia. Complication following aspirin. Following aspirin intake, Reye's syndrome, which is nothing but it is a fatty liver, fatty degeneration of liver called as Reye's syndrome. Okay, so these are the various complications seen in chicken pox. If they ask which is the most severe complication, most common of course secondary bacterial infection, most severe is varicella pneumonia. Okay, most severe is varicella pneumonia. Coming to complication in pregnancy, if chickenpox occurs in pregnancy, they say that mothers will have high risk of pneumonia. In contrast, the fetus will have increased fetal anomaly, which is more common during first trimester, and the common fetal anomaly will be cicatricial skin lesion. And limb hypoplasia, skin lesions plus limb hypoplasia. These two are specific for the varicella zoster infection of fetus, cicatricial skin lesion and limb hypoplasia. If infection occurs before delivery, then what happens? They say that if the infection occurs one week, the maternal antibodies will be produced, which will prevent transmission. Hence, the newborn baby will be mostly asymptomatic. They are mostly asymptomatic. In contrast, if the infection occurs from -5 to +2 days of birth, then during such a less time period, the protective maternal antibodies are not produced. They would not have produced. So, in the absence of protective maternal antibody, there occur dissemination of varicella zoster virus that leads to severe form of chicken pox in the newborn baby. So, this is how you have to remember. This is a very important aspect for exam. Zoster I have already told. Zoster usually occurs in adult as a reactivation, and the reactivation leads to the various rashes. The latency is where they undergo latency, ophthalmic branch of trigeminal nerve. Zoster will have certain complications like Ramsay-Hunt syndrome, which is the facial nerve involvement, geniculate ganglia of facial nerve. Other than that, zoster ophthalmicus, zoster ophthalmicus. Can you tell me the rashes, how they differ between chicken pox and zoster? They say that the chicken pox, the rashes are bilateral and diffuse, whereas zoster, the rashes are unilateral and segmented. Chicken pox, the rashes are distributed along with the distribution of rashes in chicken pox along the spinal cord D3 to L3. Here of course, as I told you, ophthalmic branch of trigeminal nerve. Through this the rashes will be distributed. Fine. So, this is all about chicken pox and zoster. Let us now discuss cytomegalovirus. Cytomegalovirus is the largest herpes virus. It is called as cytomegalo because the name says here you will have enlargement of virus infected host cell. The host cell undergoes cytomegalic. It replicates slow and spreads slow. And it shows strict host specificity, whereas the herpes simplex does not show host specificity, whereas cytomegalovirus strictly shows host specificity. A characteristic inclusion body is seen. They say that which is described as owl's eye appearance. Which is both intra-cytoplasmic and intranuclear inclusion, which is described as owl's eye appearance. Okay. Coming to the manifestation in the form of congenital, adult, in renal transplant individual and in HIV individual. 4 category of manifestation. Congenital cytomegalic disease, they say that it is characterized by hepatosplenomegaly. Apart from that, 3C plus 2M, that is chorioretinitis, convulsion and cerebral calcification. 2M, microcephaly and mental retardation. What about in adult? In adult, the cytomegalic inclusion is usually except following blood transfusion. Following blood transfusion, cytomegalovirus produces a syndrome called as mononucleosis like syndrome. What is mononucleosis like syndrome? They say that like infectious mononucleosis. What is the agent of infectious mononucleosis? Epstein-Barr virus. So, like mononucleosis, here also you will have atypical lymphocytes. However, the characteristic test, that is Paul Bunnell test, what you do in infectious mononucleosis, that test will be negative here. Hence, it is called as mononucleosis like syndrome. Okay. Atypical lymphocytosis will be there, but Paul Bunnell test will be negative. What about following renal transplant? Cytomegalovirus, they say that it is the most common infection in renal transplanted individual. However, the infection occurs after 1 month. Immediately it does not infect. After 1 month the infection occurs, and the most common form is a bilateral interstitial pneumonia. Bilateral interstitial pneumonia, okay, in renal transplanted individual. Next is in HIV individual. Cytomegalovirus infect if the CD4 count falls below 50 in HIV individual, and the most common form of infection cytomegalovirus is it can produce chorioretinitis in HIV individuals. Okay. So, these are the various manifestations regarding lab diagnosis of cytomegalovirus infection. Do not forget, the most important cell line is what cell line? Human fibroblast cell line, diploid cell line. But they say that cytomegalovirus grows slowly or fast? Slowly. They say that the incubation time is around 2 to 3 weeks. If you want to have a rapid grow, you can do a modified culture technique called a shell vial technique. Shell vial technique can be followed to have a growth in 4 to 5 days. 4 to 5 days. Other than that, you can detect specific antigen called as PP65 antigen detection in patient serum. Even antibody detection methods are available which can detect IgM as well as IgG. DNA PCR also can be done. Okay, so these are the various diagnostic tools for cytomegalic infections. Treatment wise, the drugs are different. Here the drug of choice is ganciclovir, cidofovir. Okay, so these are the certain anti-CMV drugs which are Foscarnet, one more drug. The acyclovir which is given in herpes, this is not effective. This is not effective. Next is Epstein-Barr virus. Epstein-Barr virus, it infects B cells. Why it infects B cell? Because B cell will have receptors for Epstein-Barr virus known as CD21 or C. for Epstein-Barr virus infects B cell, following which B cell undergo immortalization. B cells undergo immortalization and polyclonally activation. It will undergo polyclonal activation that leads to hyper gamma globulinemia. Hyper gamma globulinemia, and in response to this, when you have B cells undergoing immortalization, polyclonal activation, and which leads to formation of various non-specific immunoglobulins, hyper gamma globulinemia. In contrast to all this, the T cell, the bystander T cells, they will become hyperactivation and they will become atypical. Okay. So, please remember the atypical lymphocytes are not B cells, they are T cells. To be more specific, they are CD8 T cells. Okay, so this is what you have to know about the pathogenesis. Coming to the manifestation, it is one of the important oncogenic virus, can cause various oncogenicity, which can range from Burkitt lymphoma, African patient, it can cause Burkitt lymphoma, Hodgkin lymphoma, okay, nasopharyngeal carcinoma. This is usually common in Chinese patient, nasopharyngeal carcinoma, okay, Chinese patient, and salted fish intake, nitrosamine intake, all these are predisposing factor. Burkitt lymphoma, Hodgkin lymphoma, nasopharyngeal carcinoma, hairy cell leukoplakia, Duncan syndrome, which is a X-linked lymphoproliferative disorder, X-linked lymphoproliferative disorder. And of course, last but not the least is infectious mononucleosis. So, let us discuss a bit about infectious mononucleosis. Infectious mononucleosis, also called as glandular fever or kissing disease. Usually the most common age group will be the young adolescents. And it is characterized by atypical lymphocytosis, especially the CD8 T cells will be increased at least by 10%. Hepatosplenomegaly, lymphadenopathy, that is why it is called as glandular fever, lymph node enlargement, and rashes following ampicillin therapy. If you wrongly treat with ampicillin, then the rashes will develop, rashes following ampicillin therapy. So, all these are the clinical manifestation. Diagnosis: the non-specific antibodies can be detected by Paul Bunel test. Paul Bunel test is done to detect antibody against sheep RBC antigen. Specific or non-specific? Non-specific. So, whenever Paul Bunel test is positive, the confirmation is done by a test called as differential absorption test and monospot test. All these are done for confirmation. and because it is non-specific, hence the use of Paul Burnell test is been decreased now, because now we have specific antibody detection methods are available. Various antibodies against the specific EBV antigen. The specific EBV antigens like Epstein-Barr virus nuclear antigen (EBNA), Epstein-Barr virus nuclear antigen, viral capsid antigen, viral capsid antigen. Okay, nuclear antigen, capsid antigen, and early antigen. All these are three important EBV specific antigen against which the antibodies are detected. Okay, so now we will discuss about human herpes virus 6. It is the agent of sixth disease, which is called as Roseola infantum or Exanthem subitum. Roseola infantum or Exanthem subitum. Human herpes virus 8, this particular virus is of course it infects B cells like Epstein-Barr virus. It is associated with Kaposi sarcoma, in HIV individual. Apart from that, it can also cause Castleman syndrome. Castleman syndrome and primary effusion lymphoma. Primary effusion lymphoma. Okay, and drug of choice is again, they say that ganciclovir, foscarnet, all these are given. What drugs are given to cytomegalovirus? The same drugs are given here. Okay, so this is all about human herpes virus 8, and it is quite endemic in Africa. Quite endemic in Africa. So let us now discuss about other DNA viruses. Other DNA viruses, of course, hepatitis B we will discuss later along with other hepatitis viruses. Now let us discuss 3P and AB. 3P stands for pox, parvo and Papua virus. Parvo. Parvo is the smallest virus and it is the only DNA virus to have a single stranded DNA. Okay. Of course, it can cause various manifestations. Most important is fifth disease. Fifth disease also called as erythema infectiosum, characterized by rashes. Rashes give rise to a slapped cheek appearance. Other than that, lymphadenopathy and arthralgia. So this is the most important manifestation of parvovirus. Apart from that, they can cause other manifestations like aplastic crisis in sickle cell anemia patient. Sickle cell disease patient, they can cause aplastic crisis. Fetus, they can produce non-immune hydrops fetalis. Other than that, erythrophagocytic syndrome. Okay, so all these are various manifestations produced by parvovirus infection. Among these, the most important is fifth is or erythema infectiosum. Coming to human papilloma virus, papova virus. Papova virus, which include human papilloma virus, other than certain other viruses like JC and BK virus. JC virus and BK virus. JC virus can cause PML, stands for progressive multifocal leukoencephalopathy. BK virus can cause renal infection, and of course the most important is human papilloma virus. So let us discuss about HPV now. Human papilloma virus, the low risk, human papilloma virus, the most important manifestation will be CA cervix. Okay, CA cervix is due to the serotype, high risk serotype. Example 16, 18, 33, 45, etc. Whereas cervical intraepithelial neoplasia will be produced by low risk serotype like 6 and 11. They can cause CIN, cervical intraepithelial neoplasia. Other benign condition caused by HPV, example, they can cause various type of warts, plantar wart, genital wart, common wart. Genital wart is called as condyloma acuminata. And one more condition which is called as epidermodysplasia verrucoplasia. Epidermodysplasia verrucoplasia. It is again a important condition produced by human papilloma virus. Okay, and please remember, CA cervix is a vaccine preventable cancer. So now we have well established vaccine for human papilloma virus, and these vaccines are subunit vaccine, particularly E6 and E7, which are the oncogenic proteins against which the vaccines are produced. These are used in vaccination, against which the protective antibodies are produced in serum. There are two commercial brands available, Cervarix and Gardasil. These are the two commercial brands available. Cervarix includes, it is an example of bivalent vaccine which includes only the high risk serotype. Gardasil is an example of quadrivalent vaccine which includes high risk as well as low risk. All the four serotypes are included. So this is about human papilloma virus. Now let us discuss on pox virus. Pox virus is a small, it is the largest virus. It is the only DNA virus that replicate in where? Cytoplasm. Most of the DNA virus, they replicate in nucleus. Pox viruses, they are brick shaped. They are brick shaped, and most of them are animal viruses. very few can cause infection in human, and those viruses are variola, vaccinia and molluscum contagiosum virus. Molluscum contagiosum virus. Coming to variola, that is smallpox. Smallpox, the agent is variola. They ask various questions related to the timeline of smallpox. The last natural case of variola major was reported in 1975 in Assam, whereas the last natural case of variola minor was reported in 1977 in an African country called as Somalia, and 3 years after that, that is 1980, 8th May 1980, where the WHO declaration of smallpox eradication took place. It was declared to be eradicated on 8th May 1980. Okay. Clinically, you should know to differentiate smallpox rash and chickenpox rash. Smallpox, they say that the rashes are on extensors and on extremity, whereas chickenpox, the rashes are on flexor and on face. Smallpox, the rashes, there is one stage evolution, all the rashes appear at the same time, whereas chickenpox rashes appear in multiple crops. Smallpox fever disappears on appearance of rash, whereas in chickenpox fever appears with each crop of rash, and rashes are always deep seated in smallpox, whereas chickenpox, the rashes are superficial. So, this is how you can differentiate the smallpox rashes and chickenpox rashes. Regarding the laboratory diagnosis, you can remember that they produce pock like lesions on chorioallantoic membrane of egg, and please remember the variola versus vaccinia. How to remember is, vaccinia, the pocks are larger and necrotic and hemorrhagic pox in compared to the pox of variola. And ceiling temperature, ceiling temperature means what? Ceiling temperature is the maximum temperature beyond which the pock formation is inhibited. The maximum temperature beyond which the pock formation is inhibited. They say that the ceiling temperature is higher for variola, I mean vaccinia, than variola. Vaccinia, it is 41 degree, whereas variola, the ceiling temperature is around 38 degree. So, this is how you can differentiate variola and vaccinia. One more difference is the inclusion body. Inclusion bodies, variola, it is called as patient body, whereas vaccinia it is called as Guarnier body. This is how the inclusion bodies are different from each other. Okay, so this is about nutshell about smallpox. Then we can discuss about molluscum contagiosum virus. Molluscum contagiosum virus can produce warty nodules with a dimple at center. This is a characteristic feature of molluscum lesions. Transmission by most commonly it is transmitted by contact, rarely by sexual. Of course, most commonly the age group will be children, where it is transmitted by sexual. Rarely adults are affected, where sexual transmission is reported. Direct contact for children, sexual transmission for adult. Fine. And it is a non-cultivable virus. So, when you do a microscopy, you can get the inclusion bodies, which are called as molluscum body, intracytoplasmic inclusion body called as molluscum body. These molluscum bodies are also called as HP body. HP body stands for Henderson-Patterson body. Henderson-Patterson body. Okay. So, this is all about molluscum contagiosum virus. Then a bit about adenovirus. Adenovirus 11 and 21. 11 and 21 can cause hemorrhagic cystitis. Hemorrhagic cystitis, which other drug can produce? Cyclophosphamide. Adenovirus 40-41 can cause infantile diarrhea. Various ocular manifestation can be produced, like swimming pool conjunctivitis, pharyngoconjunctival fever, and epidemic keratoconjunctivitis. Epidemic keratoconjunctivitis. Apart from that, upper respiratory tract infection and very rarely lower respiratory tract infection, mainly upper respiratory tract infection. So, these are the various manifestations of adenovirus. Bacteriophage. Bacteriophage are also double stranded DNA viruses. They are tadpole shaped. They have a hexagonal head and a tail with tail fibers. Hexagonal capsid. The head or the capsid is in the form of hexagonal shape, which accompanies DNA, and a tail with a tail fiber. Replication is same like any DNA virus, except that there is no the uncoating step is absent. And one more exception is they can have two life cycle, lytic and lysogenic. Lytic is the replicate in cytoplasm and the release by lysis of the host cell, lysis of the bacteria. Bacteriophage means what? The virus that infect a bacteria. So, in lytic phase they replicate in the bacterial cytoplasm and they release by lysis of the bacterium. Lysogenic phase characterized by they go to the nucleus and they integrate with bacterial DNA, they integrate with bacterial chromosome and they undergo lysogenic conversion. They undergo lysogenic conversion, and at times when they want to come out, the lysogenic to lytic conversion takes place. So, the lysogenic phase, if it wants to come out of the bacteria, it has to be disintegrated from the nucleus, from the chromosome, comes to the cytoplasm, multiply like a lytic phase, then undergo bacterial lysis and they are released outside. So, that is how the lysogenic phase can come out. So, lysogenic to lytic conversion, it has to take place for the lysogenic phase to come out. Okay. Certain uses of bacteriophages. So, bacteriophages can code for toxin. There are various toxin clubbed as ABCD, A and C of what? Streptococcal pyrogenic exotoxin, botulinum toxin C and D, cholera toxin, diphtheria toxin and EHEC viroceratoxin. So, the 5 important toxins which are coded by bacteriophage. Other than that, bacteriophage can be used for typing, phage typing. Where to use? Where we do phage typing? Very good. Staph aureus pattern method. VI phages are used for Salmonella typhi. Lysi phase are used for Brucella, and phage typing is also used for Corynebacterium diphtheria, though it is not commonly done, but it is used. Vibrio, classical versus alter. Of course, there are various biochemical reactions. Apart from that, they have their own bacteriophages to infect, based on which also you can differentiate classical and alter. So, all these are the places where phage typing is done. Other than that, phage can be used for therapy, because you know that bacteriophages they infect the bacteria and they lytic phages they destroy the bacteria. So, this property is used for treatment of bacterial disease. There are many burn surfaces and other pyogenic wound infections where bacteriophages are, it is a new concept of what is upcoming. Bacteriophages are, it is an alternate to antibiotic therapy, because we have so much of antibiotic resistance developed by bacteria. So, phage therapy is considered as an alternate for antibiotic therapy, especially it is tried for burn surfaces. Then bacteriophages are used for diagnosis also. Especially mycobacteriophages. Mycobacteriophages are used for diagnosis of Mycobacterium tuberculosis. Phage assay. Phage assay is done to count the number of bacteriophages in a specific medium, in a specific population. How much bacteriophages is there, that can be counted by phage assay. Okay, so this is all about bacteriophages. So this finishes your DNA viruses. Myxoviruses divided into orthomyxovirus and paramyxovirus. Influenza, paramyxovirus virus has parainfluenza, mumps, measles and respiratory syncytial virus. So, these are the major viruses under each family. Can you tell me which is the most important difference between orthomyxo and paramyxo? Orthomyxo replicate in nucleus, whereas paramyxo virus they replicate in cytoplasm. Orthomyxo virus influenza has a segmented RNA. How many segment? 8 segment. Paramyxo viruses they have a unsegmented linear RNA. They also vary from each other by the property of expressing heme agglutinin and neuraminidase antigen. Myxoviruses they have heme agglutinin and neuraminidase antigen. This heme agglutinin antigen is responsible for, they say that on the surface of influenza virus there is an antigen called as heme agglutinin antigen. This antigen is responsible for binding to the receptors of RBC. So, this is responsible for a reaction called as heme agglutination reaction. When you add influenza virus to a drop of RBC, the influenza virus will be clumped on the surface of RBC, which is called as heme agglutination reaction. Influenza virus has got one more antigen, mushroom shaped antigen called as neuraminidase antigen. This neuraminidase antigen has a property of replacing heme agglutinin antigen and self binding to the same receptor. That results in reversal of heme agglutination. The reversal of heme agglutination reaction is called as elution, described as elution. So, various myxoviruses they vary from each other in their expression of HA and NA antigen. Like for example, influenza, parainfluenza and mumps, they express both HA and both are. Measles expresses only HA antigen, no neuraminidase antigen, whereas respiratory syncytial virus both NA and HA both are absent. So, that is how their expression of HA and NA antigen. So, coming to the coming to the orthomyxovirus, that is influenza. Influenza virus, they say that the HA antigen of influenza virus undergo antigenic variation. The antigenic variation is of two types. What are the two types of antigenic variation? Antigenic shift and antigenic drift. Which is a major change, shift or drift. Shift is shifting from one place to other place, major change. Drift means dragging, just you drag the thing from a place to the other place. So, shift is always a major change, and because it is major change, it results in pandemics and periodic epidemic. Not periodic epidemic, explosive epidemic. It results in pandemics and major explosive epidemic, whereas drift results in outbreaks and small periodic epidemics. Okay. Antigenic shift is due to, you know that influenza has got three subtype, serotype A, B and C. Antigenic shift is due to always only due to type A, whereas drift can be due to type A and B, both can cause antigenic drift. Antigenic shift is due to genetic reassortment or recombination. You know that influenza has got how many segments? 8 segments. Between the 8 segments you will have genetic reassortment, and different influenza viruses, if they infect the same cell, then between the genetic segments of different influenza, avian influenza, swine influenza, they can have a genetic reassortment. So this results in antigenic shift, whereas antigenic drift is just due to a point mutation. Shift occurs rarely. They say that antigenic shift occurs every 20 to 30 years, whereas drift occurs every 2 to 3 years. So drift occurs very frequently than antigenic shift. Okay. Coming to the clinical manifestation, influenza can produce upper respiratory tract infection, flu-like manifestation. Complications, they say that secondary bacterial pneumonia is more common than influenza induced pneumonia. Okay. In secondary bacterial pneumonia, the various agents like Staph aureus, okay, pneumococcus, all this, H influenza, all this can cause secondary bacterial pneumonia than influenza induced pneumonia. One more complication is Ray's syndrome following aspirin intake. This is common in influenza B. Influenza B can produce Ray's syndrome following aspirin intake. Fine. So these are the common clinical feature of influenza. Now what I will tell you is specific clinical features, like in case of avian flu and H1N1 flu. Avian flu is, which is the most common strain of avian flu? H5N1 is the most common strain of avian flu. It was started from 1997 from Hong Kong. In India it is seen in 2003 onwards, and they say that the transmission is only from bird to man. There is no man to man transmission. However, this particular avian flu is highly virulent, as it has PB1F2 gene, which is a virulent gene which is expressed by avian flu strains. In spite of its high virulence, there is no man to man transmission, hence it has produced more mortality. However, the morbidity is less. Very few cases only have been reported, because there is no man to man transmission. The drug of choice is again oseltamivir. Oseltamivir is the drug of choice. Apart from H5N1, the other avian flu strain, the other avian flu strains are, you can remember, as 77, 79 and 92, that is H7N7, H7N9 and H9N2. These are the other avian flu strains. Among these, H7N9 had caused an outbreak in China in 2013. Okay. So, this is about avian flu. Now, we will discuss about H1N1 flu. Is it a swine flu? Very common language, it is called as swine flu. Is it the correct word or not? H1N1 flu is a combination of genetic recombination of 4 strain, 1 avian strain, 2 swine strain and 1 human strain. And this combination, the genetic recombination has taken place inside pig. Pigs are the mixing vessel. Inside the pig, the genetic recombination has taken place. Hence, they say the WHO strictly told that do not use the swine flu word, it is not the correct word. And it was started in 2009 April in California, and by 2 to 3 months it has spread to the whole world. The WHO has declared it as a pandemic in June 11, 2009. So, in 2 to 3 months it has spread the whole world. The migration was so fast that it has affected the entire world. How it is possible? The reason is there is well documented man to man transmission. As man to man transmission is well documented, hence the transmission was faster. And we all were lucky in 2009 because the virus was less virulent, though it has caused more number of morbidity, but as the PB1F2 gene was lacking, the H1N1 of 2009 was less virulent. So, morbidity was more, however, mortality was less. Whatever mortality was reported, they were telling that it was due to the secondary bacterial infection, underlying disorders, underlying health related diseases, immunocompromise, old age, all that, because of that the mortality was more, otherwise the virus was less virulent. So, from 2009 to 2014 we were in a post pandemic period. The entire world was in a post period except India and New Zealand, where the local intense transmission was ongoing. Local intense transmission was ongoing, but it was to a lesser extent. But in 2015 January to April, this was the time when again a explosive outbreak or explosive epidemic has occurred in India, where almost 34,000 cases were reported. Maximum cases were reported from Gujarat, Rajasthan. These two states were the most affected state. Among South India, of course, the Telangana was the most affected state. Okay, so this was like that, and the diagnosis of H1N1 flu, they say that you do a reverse transcriptase real time PCR. The reverse transcriptase real time PCR is done to detect the specific HA and NA genes. Treatment: the neuraminidase inhibitor like oseltamivir. Which was available as Tamiflu or Zanamivir, which is available as a inhalational form. Oseltamivir and Zanamivir available as Tamiflu tablet, whereas Zanamivir as inhalational sprays. Chemoprophylaxis also oseltamivir is given. Now we have vaccine prophylaxis also. Both the live attenuated as well as the killed vaccines are available. Both form of H1N1 vaccines are available. So this is all about swine flu, and you can tell me what are the actual swine flu strain. The actual swine flu strains are 11, 12 and 32. That is H1N1 of 1918, then H1N2 and H3N2. So these were the swine flu strains which had caused the epidemics and the pandemics in the past. To be more specific, H1N1 of 1918, they say that particular swine flu strain was so virulent that it has wiped out 1/6 of the world population. The number of deaths were at that time 1/6 of the world population, which was more than the number of deaths during the First World War. During 1918, the First World War was going on, and the report says that the number of deaths were more in this pandemic than the First World War deaths. In contrast, the H1N1 of current days, 2009 H1N1 is less virulent. So now I will tell you the sialic acid receptors. Sialic acid receptors and how they are important for influenza pathogenicity. Sialic acid are the host cell receptors. They are the host cell receptors to which influenza infect. As I told you, influenza, which is the receptor? Influenza, the receptor is HA antigen. That binds to sialic acid receptor of mammalian cell. Okay, there are two types of sialic acid receptor. Alpha 2,6 receptors, they are present in upper respiratory tract of human being. Alpha 2,3 receptors, they are the avian. So alpha 2,6 receptors are the human receptors. They are present on the human upper respiratory tract, whereas alpha 2,3 receptors, they are the avian receptors. They are usually present in the intestinal epithelial cells of avian flu. In human, they are present in lower respiratory tract, but very few number, whereas alpha 2,6 receptors are present abundant in the upper respiratory tract. So that tells you how the, so what is the receptor for the human strain? For the human strain of influenza virus, the receptor is alpha 2,6, which is present in upper respiratory tract. That is why most of the influenza, the manifestation is URTA. But the avian flu strains, they infect alpha 2,3 receptors of intestinal epithelium. So in the birds, the avian flu strains in the bird will produce a intestinal manifestation, not respiratory manifestation. But in same strain, if they infect human, in human the upper respiratory tract, they don't have alpha 2,3 receptor. Alpha 2,3 receptors are extremely scanty in upper respiratory tract. That is why they do not infect humans. By chance, whichever few alpha 2,3 receptors are there in upper respiratory tract, if by chance if they infect that, then through that they will come to lower respiratory tract, and lower respiratory tract, of course, they will have alpha 2,3 receptors, so they can cause lower respiratory tract infection in human. So that is how they say that the avian flu strains, they usually do not infect human, because humans in the upper respiratory tract alpha 2,3 receptors are absent or very scanty. That is, only few individuals only will get avian flu. But once they infect human, they will go to the lower respiratory tract, and lower respiratory tract will have alpha 2,3 receptors by which they can cause severe manifestations. But always the number of cases will be very less, because upper respiratory tract only is the site through which the virus will enter, and we do not have alpha 2,3 receptors in the upper respiratory tract. So, this is the sialic acid receptor theory for influenza virus. And why pigs are a mixing vessel? They say that pigs are the most common mixing vessel of influenza virus. Why? Because pigs, the cells contain both alpha 2,3 and alpha 2,6 receptors. That is why pigs, the same cell can be infected by avian flu strain as well as can be infected by human strain. That is why inside the human, inside the pig cell, all the avian flu strains will go inside, the swine flu strains will go inside, and the recombination will take place. That is the reason why pigs are the common mixing vessel. Okay, so the sialic acid receptor theory is very important to understand the pathogenicity of influenza virus. So, this finishes your orthomyxovirus. Now, we will discuss paramyxovirus. Paramyxovirus, to start with mumps. Mumps virus is the most common virus to cause childhood parotitis. Is the most common cause of childhood parotitis. And please remember, parotitis is usually bilateral than unilateral, and it is usually infected in 70 to 90% of cases. And please remember, though parotid is the most common gland to be infected, but at the same time you have to remember that other salivary gland are also rarely infected. However, parotid is the most common gland to be infected. Coming to the complication, the most common complication is yes, orchitis. Orchitis is more unilateral than bilateral. Unilateral orchitis is more common than bilateral. That is the reason why infertility following mumps orchitis, common or rare? Rare. Second complication is aseptic meningitis. If they ask most common manifestation in female, answer will be aseptic meningitis. Overall, it is orchitis. Then pancreatitis, euphoritis, all these are other complications. There is something called as atypical mumps. Atypical mumps means there is no parotitis at all. As I told you, parotitis will be there in 70 to 90% of cases. That means in 10% of cases there will be atypical mumps. There is no parotitis. Directly the child is presented with aseptic meningitis. This is called as atypical mumps. And please remember, following recovery, deafness is permanent. Everything will be recovered, but what doesn't get recovered is deafness. Okay. And certain other MCQs like MMR. MMR means what? Mumps, measles, rubella. Here, as far as incubation period is concerned, the Harrison derived incubation periods are mumps 19 days, measles 10 days, rubella 14 days. Well, how long the patient is infectious? The patient is infectious. In mumps it is from -1 to plus 1 to 2 week of parotitis. Mumps, the patient is infectious from -1 to plus 1 week of parotitis, 1 to 2 weeks of parotitis. Measles, the patient is infectious from -4 to plus 5 days of rash. This is all, these are very important MCQs. -4 to plus 5 days of rash. In rubella, the patient is infectious from -1 to plus 1 week of rash. Okay, so this is the general principles, figures what you need to remember. Fine. Don't forget the vaccine strain in mumps is Jerry Linston. It is given either alone or along with MMR vaccine. Okay, it is given either alone or along with MMR vaccine. Then let us discuss measles. Measles is the most common cause of childhood rash. And one more thing what I forgot to tell you is, MMR in 2 poxes, there are few things which are common, like there is no carrier. MMR in 2 poxes stands for mumps, measles, rubella. 2 pox means chicken pox, smallpox. All these 5 viruses, there is no carrier, and the only source of infection will be cases. There is no animal reservoir also, and once you are infected, you will be lifetime immunized. Though it does not happens always, but they say that once infected, the immunity usually lasts for lifelong. So these are the common features for all 5: mumps, measles, rubella, chicken pox and smallpox. Coming to measles, what is the incubation period of measles? I told you 10 days. So can you tell me at 10th day what you will develop? The 3 important manifestations are fever, rashes and Koplik spot. So can you tell me which appears first? Easy to remember, you have to remember just alphabetically. First F, then K, then R. So 10th day fever, 12th day Koplik spot and 14th day rash. The Koplik spots, of course you know they are, what is the Koplik spot? They are the bluish white discoloration of buccal mucosa. They are pathognomic of measles. They are pathognomic of measles. Rashes, the peculiarity of measles rash is, first it will appear behind the ears, then it will spread. The rashes of the measles rash first appears behind the ears. So this is again a peculiarity of measles rash. And one more MCQ they ask, In HIV infected individual, the rashes will be absent. No rashes in HIV individual. Okay. Complications in measles. The most common complication will be secondary bacterial infection in the form of otitis media, pneumonia, etc. There could be measles induced pneumonia also. Measles pneumonia is called as giant cell pneumonia or Hesset pneumonia. CNS complication, the most dreaded complication is SSP. SSP is common or rare? This is the severe most, however at the same time it is the rarest complication. What is SSP? Subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis, SSP. So, SSP, the occurrence is 1 in 3 lakh. 1 in 3 lakh cases SSP occur, and SSP has a higher mortality rate. Mortality rate is always high. The onset is, the risk is more if primary measles occurs less than 2 year age. If primary measles occur less than 2 year age, then the chance of development of SSP always higher, and SSP usually occurs 7 to 10 years after the primary measles. It occurs 7 to 10 years after the primary measles. Okay, so this is all about complications of measles. Vaccine, Admostem Jagrivstem is a live attenuated vaccine. Usually it is given at 9 months, along with what? Which vitamin? A. If given, during outbreak, if the measles outbreak is going on, then it is given at 6 months. In such case, you have to repeat at 9 months. During outbreak, if you have to give at 6 months, in such case you have to repeat at 9 months. And toxic shock syndrome can be a complication because of contamination of vaccine vial with Staph aureus. Okay. And one more aspect is following exposure. What is the criteria following exposure? Following exposure, you can give measles immunoglobulin within 3 days of exposure. You can also give vaccine within 3 days of exposure. Either measles immunoglobulin or vaccine is given. Please remember, never both. Is only condition where combined immunization is not given. You have to maintain at least 2 to 3 week of gap. Okay, combine into 2 to 3 months of gap. Okay, so combined immunization is not given here. The only case where the combined immunization is not given. Okay, so this is all about measles, and regarding the measles elimination strategy, they say that KFC strategy stands for keep up, follow up and catch up. Catch up the unvaccinated individual, keep up the immunization program. So like that this strategy is been followed for measles elimination, keep up, follow up and catch up. Okay, so this is all about measles. Then para-influenza virus. Para-influenza virus, only one MCQ they ask, it is agent of crop. It causes crop. Crop means the whole tract is infected, that is it is acute laryngo tracheal bronchitis. The whole respiratory tract is affected, crop, para-influenza virus. Then the next is respiratory syncytial virus. Respiratory syncytial virus is the most common cause of bronchitis in infant, bronchiolitis in infant. Okay, and the the respiratory syncytial virus, they say that it can they say that the most common age group will be affected is 6 weeks to 6 months, and severe cough, severe dry cough will be the most common presentation. Exacerbation of asthma can take place. If respiratory syncytial virus is infected, then there can be acute exacerbation of bronchial asthma. Okay. Diagnosis, they say that multinucleated giant cells will be seen. In this context, I want to add one point. In measles, you can write down, measles also multinucleated giant cells are seen, which are called as Warthin Finkeldy giant cell. Warthin Finkeldy multinucleated giant cells. Similarly, multinucleated giant cells are also seen in respiratory syncytial virus. The drug of choice is ribavirin. Ribavirin is the drug of choice in RSV. Okay. Next is rubella. Rubella is also called as German measles. Similarly, what is the other name of measles? Measles is also called as rubeola. Rubella is also called as German measles. What is the incubation period of rubella? 19, 10 and 14 days. Okay. And as I told you, MMR and 2 poxes, the common feature is there is no carrier, source is always a case, and the incubation period is 14 days. After 14 days, the first manifestation will be rashes, followed by lymphadenopathy, especially occipital and post auricular lymphadenopathy is common. Occipital and post auricular lymphadenopathy is common, and there is a characteristic spot seen in rubella called as Frochmere spot. Koplik spots are seen in measles, whereas Frochmere spots are seen in rubella. The Frochmere spots are nothing but they are the petechial spot. petechial spot in soft pellet and uvula. The petechial spots in soft pellet and uvula. There is something about congenital rubella what you have to know. Congenital rubella, which is the period where maximum transmission takes place. Maximum transmission as well as the maximum severity occurs in first trimester. If somebody will ask you which is the triad of congenital rubella syndrome, the triad of congenital classical congenital rubella syndrome is nothing but eye, ear and heart. Among these three, which is the commonest? The most common congenital rubella presentation is sensory neural deafness. Sensory neural deafness is the most common presentation. Most common ocular is cataract or not? Most common ocular presentation is, they say that salt and pepper retinopathy is the most common ocular presentation, followed by the second most common ocular representation is cataract. Most common cardiac defect, most common cardiac defect is patent ductus arteriosus, followed by pulmonary artery stenosis, followed by ventricular septal defect, VSD, ventricular septal defect. Okay, so this is how you have to remember the classical congenital rubella syndrome. There is expanded rubella syndrome, expanded congenital rubella syndrome. In addition to the classical feature, there are additional features such as hepatosplenomegaly, IUGR, and a typical finding called as blueberry muffin syndrome. Blueberry muffin syndrome is characterized by, they say that you will have hepatosplenomegaly plus petechial spot, thrombocytopenia plus petechial spot. In various places, which is called as blueberry muffin syndrome. Okay, so this is about congenital rubella. Now let us discuss about the vaccine. Rubella, the vaccine is RA27/3. It is given either alone or along with MMR vaccine. It is usually given after 1 year. And please remember, if given in adult, then the pregnancy has to be avoided for 28 days. If it is given in adult females, then the pregnancy has to be avoided at least for 28 days. The reason is it is a teratogenic virus. Okay, so this finishes your myxovirus. Okay, so the next topic will be chapter number 4.4, and which include 3 important viruses. All these 3 are extremely important as far as exam is concerned. So let us start first with arboviruses. Arboviruses, as the definition says, they are arthropod borne, arthropod transmitted RNA viruses. They are arthropod transmitted RNA viruses, and the important viruses which are prevalent in India are among the toga viruses chikungunya, among the flaviviruses it is the Japanese encephalitis virus, dengue, Kasunar forest disease virus. All these three are important in India. Other than India, in the world, among the viruses which are important is yellow fever. Among the flavivirus, yellow fever virus is important for exams. Other than that, the newer flavivirus which has caused threat in 2016, that is Zika virus. Zika virus also is nothing but it is a flavivirus, Flaviviridae family. So, these are the important arboviruses which are useful for the exam point of view. Coming to the vector is concerned, please remember chikungunya it is Aedes, dengue also Aedes, yellow fever also Aedes, Japanese encephalitis Culex, KFD tick, and do not forget the recently outbreak of Zika virus is also transmitted by Aedes mosquito. Okay, so with this introduction let us start one by one. We can start with chikungunya virus. Chikungunya, they say that it is an excellent example of re-emerging infection. Why it is called as re-emerging infection? Because from 1973 to 2005, the entire world was free from chikungunya virus. Before 1973, much more cases were there, but this is the period where no infection were there at all. In 2005, again it has reappeared in an island that is called as Reunion Island. This is an island near Indian Ocean. So, this island the virus has reappeared in 2005. After that it has spread to the various part of the world again, and India has been affected since 2006. Of course, do not forget before 1973 various part of the world including Africa and India cases were there. Only from 73 to 2005 no cases were there, hence it is called as re-emerging infection. Why it is why it has re-emerged? What was the reason behind the re-emergence? They say that the reason behind the re-emergence is the usual vector is Aedes aegypti. Aedes aegypti is the usual vector. They say that in the re-emergent virus, the vector was supposed to be Aedes albopictus. Aedes albopictus was the vector in 2005 when the virus has re-emerged, and also there was a mutation which is described as A229 mutation in the virus. So, these are the two reasons why the disease has reappeared again in 2005 onwards. Okay. Clinically, the features are almost resemble with dengue, except that the hemorrhagic manifestations are rare in chikungunya. Outbreaks are shorter, and polyarthritis is more common in chikungunya than in dengue. Otherwise, the features are quite overlapping. You cannot differentiate chikungunya from dengue. Okay, so this is all about chikungunya virus. Then let us discuss bit about Japanese encephalitis. Japanese encephalitis virus was first seen in Japan. It is called as Japanese encephalitis B virus. Why? Because at that time in Japan there was another encephalitis going on. Another encephalitis going on which was called as von Economo disease. So this was a encephalitis disease going on in Japan during the discovery. So to differentiate from von Economo disease, they have given Japanese encephalitis as B. Okay, that is why the name B has come. And the vector of Japanese encephalitis B virus is Culex. Culex is a vector. Worldwide it is Culex tritinorinchus, whereas in India the vector is Culex vishnui. India the vector is Culex vishnui, worldwide the vector is Culex tritinorinchus. Coming to the reservoir, they say that birds are the reservoir. Aldrid birds, aldrid and heroine birds are the reservoir, whereas pigs are considered as amplifier host. Amplifier host is the host where the virus multiplies exponentially. So pigs plays a very important role in the transmission of Japanese encephalitis. They are the amplifier host. And cattle and buffalo are mosquito attractant. They are mosquito attractants, and horses are considered as the only animal to be symptomatic. Horses are the only animal to be symptomatic. Okay, so this is all about the animals. Then coming to the clinical feature, it has an incubation period of 5 to 15 days, and there is more asymptomatic cases than symptomatic cases. The ratio is, for every symptomatic case you have 300 to 1000 asymptomatic cases. This is the ratio what they ask, and the asymptomatic cases are so much that even during epidemic the number of symptomatic cases will be just 1 to 2 per village. Even during epidemic the number of cases are just 1 to 2 per village, not much. So that is why it is called as, it is a disease that shows iceberg phenomenon. It is a disease that shows iceberg phenomenon. Fine. So regarding vaccine, the live vaccine is called as 14-2 vaccine. This is a live attenuated strain, whereas the killed strains are Nakayama strain and Beijing strain. And please remember, the 14-2 strain has been incorporated in national immunization schedule in India. It has recently been included in national immunization schedule of India, and it is given in high endemic states. The 4 important endemic states where Japanese encephalitis vaccine has been recommended is Uttar Pradesh, Assam, West Bengal and Karnataka. Okay, so these are the 4 states where the Japanese encephalitis vaccine has been going on under national immunization schedule. And the most endemic state will be Uttar Pradesh, especially the Gorakhpur district of Uttar Pradesh is considered as the most endemic region for Japanese encephalitis. Fine. So, this is all about Japanese encephalitis. Then we will discuss about dengue. Dengue virus has got 4 serotypes, dengue 1 to 4, but the 5th serotype has been recently described. It has been recently described. So, totally 5 serotypes are there, but the 4 serotypes are properly characterized. 4 serotypes are properly characterized. Vector Aedes aegypti, of course, it is a day biter. It is a day biter. Patient is infectious to Aedes. How long the patient, the dengue patient, how long they are infectious to Aedes? This is a MCQ what they sometimes ask. Please remember -1 to +5 days of fever. This is the period of infectivity of dengue virus from the patient to Aedes mosquito. And once Aedes is infected, the transmission starts immediately or after some time. Say that the transmission starts after an extrinsic incubation period of 7 to 10 days. After that only the transmission starts. But once infective, it remains infective for life, as well as it transmits the virus to offspring by trans-ovarian transmission. Via the trans-ovarian transmission, that infection is ongoing to the offsprings. So, this that is how the virus has been maintained in Aedes. As far as the clinical feature is concerned, you all know there are 3 stages: dengue fever, which is called as breakbone fever or saddleback fever, dengue hemorrhagic fever, which is characterized by 5 important criteria. First is of course continuous high grade fever, then liver enlargement, then platelet count less than 1 lakh, then raised hematocrit. The last but not the least, how to know that hemorrhages have been taken place? The hemorrhages are there or not, by you can know by doing a tourniquet test. The tourniquet test should show more than 20 petechial spot per square inch area. More than 20 petechial spot per square inch area. More than 20 petechial spot per square inch area. Okay, so this is all about dengue, and the third stage is dengue shock syndrome. Third stage is dengue shock syndrome, which is characterized by dengue hemorrhagic fever plus the various features of shock, hypovolemic shock. Can you tell me which infection is more common? They say that dengue hemorrhagic fever and dengue shock syndrome can take place only when you have a mixed infection. So, mixed serotype infection is more severe in dengue. Why? The reason is there is a immunological phenomena which happens in dengue, which is called as ADE or antibody dependent enhancement. Antibody dependent enhancement is a immunological phenomena specifically seen in dengue, characterized by, they say that the antibody against the first serotype. These antibodies are usually non-neutralizing antibody. The non-neutralizing antibody against the first serotype, it usually covers and protects the second serotype from post immune response. So that is why the second serotype infection can cause much more severe infection, and among all the combination, the most dangerous combination is serotype 1 followed by serotype 2, and serotype 2 is considered as the most virulent serotype, most virulent serotype. So this is called as antibody dependent enhancement of infection. Next is about the dengue vaccine. They say that recently the vaccine of dengue has been developed. It is a tetravalent dengue vaccine using chimeric yellow fever vaccine as a base. Okay. So you know that yellow fever vaccine is an established vaccine for last decades. So what they have done is, yellow fever also is this virus also is a flaviviridae virus, so which is quite overlapping with dengue in its genetic structure. So what they have done is, they have made yellow fever vaccine, the 17D yellow fever vaccine as a base, in which they have incorporated the 4 important serotypes of dengue virus. So this is called as tetravalent dengue vaccine, and it is recently started in 2015. 2015 it has been started, not everywhere, only in Mexico it is marketed. Other places it is expected that if it is successful in its initial use, then it will be soon marketed to other places. So this is about dengue virus. And regarding the laboratory diagnosis, dengue, they say that NS1 antigen detection. This is the most important diagnostic tool for dengue, because NS1 antigen detection, these antigens can appear from day 1 up to 18 days, whereas antibodies, the IgM antibodies usually appear in 5 days, from 5 days onwards. So that is why dengue is usually not diagnosed in first 4 to 5 days if you go for only antibody detection, and that is where the NS1 antigen detection has become more important in dengue diagnosis. Fine. So MAC ELISA is the most recommended ELISA for dengue antibody detection. MAC ELISA is the most recommended ELISA for dengue antibody detection. Okay. Other than that, mosquito cell line culture, like for example Aedes albopictus cell line, this can also be used. Okay. What is the dengue situation in India? The situation of dengue in India is, it is endemic in almost all the states. It is endemic in mostly in the urban places, and approximately 31 states or union territories are endemic in dengue virus. Maximum cases are reported from Kerala. I mean, year to year the figure will change. Kerala, Tamil Nadu, Karnataka and Orissa. In the decreasing order, these are the maximum cases reported in 2014. I mean, Maharashtra is the highest burden. If you see 2014, the highest burden state was Maharashtra, followed by Orissa. In general, Kerala, Tamil Nadu, Karnataka and Orissa, but in 2014, Maharashtra followed by Orissa, they were the maximum number of cases have been reported, and it varies from year to year. Every year the number of cases will vary. Okay, and dengue 1 and the serotype 1 and 2 are the most widespread serotype. Okay, so this is all about dengue virus. Then Quesonar forest disease virus. Where this forest is located? What are the endemic area for Quesonar forest disease? They say that in Karnataka there are certain districts where the KFD is endemic. By the way, which district the Quesonar forest disease is located? Shimoga district. Shimoga district of Karnataka. Other than that, there are other districts where the KFD is endemic, like North Kannada, South Kannada, Chikmagalur, Udupi. So these are the districts where the KFD is endemic, and this forest, of course, the forest is located in Shimoga district, and KFD was previously called as monkey's disease because it was transmitted to human from monkeys. They say that 1980s the largest outbreak was reported from India. The largest outbreak was reported in India in 1980, mainly from the Shimoga district. After that, only focal cases have been reported since then. What is a vector? KFD, the vector is tick. Ticks are the vector. Manifestation wise, nothing but you will have a hemorrhagic fever plus hemorrhagic manifestations. And please remember, it is a vaccine preventable virus. There is a killed KFD vaccine which is recommended for the endemic districts. Killed KFD vaccine is recommended in endemic district. Okay. So they say that among the tick, the heart tick is the most important vector of the genus Haemophilus. Haemophilus is the genus. Heart tick is the most important vector. Okay, so this is all about KFD, Quesonar forest disease virus. Little bit about yellow fever. Yellow fever is the only arbovirus which is very important for exam, but it is not found in India. The first question which they ask, which of the virus is not found in India, in that yellow fever will be there. Okay, if it is not found in India, then where it is endemic? It is endemic in Western Africa and Central South America. It is endemic in Western Africa and Central South America. Why not found in India? what is the vector of yellow fever? Yellow fever, the vector is again Aedes aegypti, which is very well present in India, and it is endemic in Western African countries. The climate is almost like Indian climate. There is no reason why yellow fever is not found in India. They say that any time yellow fever can affect India. They have given certain reason why it is not found in India, because we have cross protective dengue antibodies. They may give partial protection against yellow fever. Second is the airport measures taken by Government of India. They say that what measures we have taken in airport. One is the unvaccinated travelers, we will send them to quarantine for how many days? Quarantine is always done for longest incubation period, and yellow fever has a incubation period of 3 to 6 days. So quarantine is done for the longest incubation period, that is 6 days. Second is the Aedes aegypti index, which is also called as the Britu index. It has to be less than 1 400 meter surrounding airport. The Britu index has to be less than 1 400 meter surrounding airport. So, okay, so these are the measures what has been taken by Government of India. Clinically, again you will have hemorrhagic manifestation, you will have hepatitis. Torus body are the inclusion body seen in yellow fever. Okay, and please remember, yellow fever has a vaccine, and the vaccine is very important for exam. The vaccine is a 17D live attenuated vaccine. In India, it is prepared in an institute called as Central Research Institute, Kesoli, and it is available in lyophilized form. Hence, it has to be reconstituted with normal saline, and the reconstituted vaccine should be used within half an hour. Okay, and they say that single dose is given subcutaneously, following which the immunity starts in 7 days and lasts for 35 years. Though immunity lasts for 35 years, but the most widely asked MCQ is the validity of vaccination certificate. That starts after 10th day of vaccination and last for 10 years. That means if they ask how frequently the boosters are given, every 10 years, or how frequently the certificate has to be renewed, renewal of certificate, every 10 years you have to renew the certificate. Like how we renew the passport, the African people, they renew along with the passport the vaccination status also. Okay, so this is all about yellow fever. Now I will tell you a bit about the recently done outbreak, that is Zika virus. Zika virus, why it is important for exam is in 2016, 15 to 16, it has made a global explosive outbreak. in South America, especially in Brazil, especially in Brazil. That is why this virus is important for exam. It belongs to Flaviviridae, where dengue is there, and of course it is single stranded RNA virus, and it is named after Jika forest in Africa, Uganda, in 1947. Okay, that means this virus is known since 1947, but it has never made any threat. In 2000, the first outbreak it has made in 2007 in an island called as Yap Island, and here the vector was Aedes hensili. This was the vector which was responsible for causing an outbreak in 2007 in Yap Island, but this outbreak was also a limited outbreak, not much threat was there. The threat was in 2015-2016 outbreak. This outbreak, it was mainly started in Brazil. It was started in Brazil in April 2015. Subsequently, it is spread to other South American country. Then of course in US also now many cases are there, and also it is spread to some of the African countries, but mainly it is Brazil. Brazil is the most affected country. So as of now, like as of January 2016, the number of cases are more than 1.5 million cases. Okay, more than 1.5 million cases. And please remember, transmission wise, I have already told it is transmitted by Aedes aegypti. Mainly it is transmitted by Aedes aegypti. Other than that, recently sexual transmission also has been confirmed, and vertical transmission. And vertical transmission, they say that common in first trimester. The first trimester, the transmission is very common, and that is the reason behind microcephaly. Zika virus is a threat because not because it causes infection in adult. Adult infections are usually asymptomatic. Why it is a threat? Because of microcephaly. So coming to the clinical feature, many are asymptomatic. Asymptomatic infection is very common. Coming to the various symptom, they say that minor illness like fever, rash, etc. will be there. So not very important, but what is important is microcephaly, and also it is associated with the pathogenesis of Guillain-Barré syndrome. Okay. Diagnosis wise, now ELISA is available, IgM ELISA. PCR also is available, reverse transcriptase PCR. Okay. And please remember, no treatment and no vaccine so far. However, trials are going on. The vaccine trials are going on. Many trials are there, including the Indian trial by Bharat Biotech. Bharat Biotech is in Hyderabad company who has also undertaken the challenge to prepare Zika virus vaccine. There are many other foreign trials are going on. So at present there is no vaccine or there is no treatment available. Another aspect of Zika virus is the declaration done by Brazil. They say that affected countries like Brazil, mainly Brazil and other affected countries, worst affected countries, have decided women not to conceive, postpone the pregnancy. Until further notice. They have told that women are requested to postpone the pregnancy until further notice is given. So this kind of drastic step they have taken. Okay. Of course, the travel of pregnant women also is restricted. Pregnant women travel to Brazil also has been restricted. Other than that, it is transmitted by Aedes. So other preventive measures are just like any other mosquito preventive measures. Fine. So this is all about Zika. So now let us discuss poliovirus. Polio is again in the outlet of going. They say that polio is in the words of eradication. Yes or no? Polio, that is why the any disease which is important for exam, either it is a new disease in the market or if the disease is going from the market, both the places it is important for exam. So Zika virus is new in the market, whereas polio is now going to be extincted from the community. So of course 3 serotypes are there. Type 1 serotype is the most common cause of wild cases. Okay, most common cause of epidemics, and it is the only serotype that can cause wild case now. Currently it is the only serotype that can cause natural cases. Wild case means what? Natural cases. Whereas type 2 not reported since 1999, that is, it is already eradicated since ages. However, it is the most common cause of VTPV. VTPV is vaccine derived poliovirus, and please remember it is the most antigenic among all the 3. It is the most antigenic among all the 3. Type 3 is not reported, no natural case since 2013. Okay, that is why I told you now only type 1 natural cases are there, and it is the most common cause of VAP. What is VAP? Vaccine associated paralytic poliomyelitis. Please remember both the terms are slightly different than each other. I will explain later. Okay. So now let us discuss about the pathogenesis. Pathogenesis, there is nothing much to know because poliovirus is quite a common virus. You all know the mode of transmission is fecal-oral mode, and from GIT, how it spread to the CNS, I mean the nervous system, which is the target site. The target site is anterior horn. Anterior horn cells are the target site. The receptors for poliovirus, the host cell receptor is CD155. CD155 molecules are the host cell receptor for poliovirus. So now you tell me how it spreads from GIT to the nervous system. They say that hematogenous spread is the most common route, followed by direct neural spread, and this direct neural spread is seen especially following tonsillectomy. That is why tonsillectomy is a very important risk factor. following tonsillectomy or maybe heavy exercise or IM injection, all these are the conditions where direct neural spread may be possible. Otherwise, hematogenous spread is the most common spread. And again MCQ is nasal body degradation. The nasal body denaturation is the earliest change. Degeneration of nasal body is the earliest pathological change in neuron. And again a MCQ what they ask is poliovirus, always the pathological change is more than the extent of neural involvement, extent of paralysis you can say. The pathological change is always more than the extent of paralysis. And you know that regarding the clinical stages, there are 4 stages. Most of the cases are asymptomatic or which is called as inapparent infection. Inapparent, 91 to 96% of cases are asymptomatic, followed by non-specific symptom or called as abortive infection. Abortive means non-specific symptom. The next stage is, the next variety is non-paralytic poliomyelitis characterized by aseptic meningitis, and the rarest variety is paralytic poliomyelitis. And please remember, the paralysis is always, the description of the paralysis is descending, asymmetric, acute, flaccid paralysis. The description is always important. Descending, asymmetric, acute, flaccid paralysis involving proximal muscle earlier than distal muscle. Involving proximal muscle earlier than distal muscle. And please remember, there is no sensory loss. And because proximal muscles are involved earlier than the distal muscle, that means which joint is involved earlier, hip or knee? Proximal joints are involved earlier, so hip muscles are involved earlier. That is why the tripod sign is there. That is why the child sits with tripod sign, that is with flexed hip. The child sits with flexed hip. Okay, so this is all about the various laboratory diagnosis, and laboratory diagnosis not much important for exam. The specimen of choice will be blood, throat swab, CSF and stool. Stool for the longest 6 to 8 weeks it will be detected in stool. And please remember, the stool culture is recommended for AFP surveillance. For for acute flaccid paralysis surveillance, the stool culture is the recommended method, and primary monkey cell line is the most commonly used cell line. Okay. Antibodies can be detected by neutralizing antibodies can be detected, or even complement fixing antibodies are also detected, but stool culture is the most recommended method. Okay. In polio, what is important for exam is vaccine. How many vaccines are there? Which is live, which is killed? OPB is live, IPV is injectable and killed. Which is Sabin, which is Salk? OPB is Sabin, killed is Salk. K for killed and Salk. Now you tell me advantages and disadvantages. We will not go into the detail because polio is going to be extincted. Just to tell me the advantages and disadvantages of OPV and IPV. First you tell about OPV. OPV, the advantages are more or disadvantages are more? More advantages, of course, that is why OPV was the vaccination of choice for ages. The advantages, of course, orally effective. It is a live vaccine, hence they say that mucosal immunity is possible, mucosal or local immunity. Feco-oral spread is possible. The feco-oral spread of vaccine virus, this was the reason behind herd immunity. The feco-oral spread of vaccine virus can lead to herd immunity. Okay, it is cheaper also. Sabin is much more cheaper than Salk. And this is the vaccination of choice during epidemic. During epidemic, only OPV is given because feco-oral spread, so the immunity will be achieved faster. All these are advantages. But the drawback of OPV is, the drawback of OPV is same as the advantages of IPV. So the drawback of OPV or the advantages of IPV will be, IPV is useful in immunocompromised patients, whereas OPV is not given in immunocompromised. IPV is more stable, whereas OPV is unstable. They say that the stability is increased by storing at -20° centigrade, as well as magnesium chloride is added as a stabilizer for OPV, whereas IPV is relatively more stable. Okay. And OPV, one more drawback is, one more disadvantage is interference. Interference means what? Presence of one virus prevent the entry of other virus. OPV contains how many serotypes? OPV vaccine contains how many? Trivalent OPV, 3 serotypes are there. So whichever serotype goes into your epithelial cell, that will prevent the entry of other 2 serotype. So you may take all 3 strains, but you may not be protected against all 3 strains. And you know that now type 1 only is the type 2 and 3 are not there. So if type 2 and 3 will be infected in your GIT, that will prevent the entry of type 1, and type 1 only is required for you. So viral interference is again a reason. Apart from viral interference, other interference like interference during breastfeeding and interference during diarrheal episode. See, breastfeeding is going on and you have given OPV. Soon after, if you breastfeed the child, then OPV will be washed away. Diarrheal episode is going on here, and if you give OPV will be washed away. So all these are the drawback. But can you tell me which is the major drawback of OPV? All these drawbacks are there from before. Still then OPV is used. But what is the major drawback of OPV which is not there in IPV? Vaccine induced cases. The vaccine induced cases are 0 in IPV. It is there only in OPV. And because of the vaccine induced cases, now there is a question that OPV should be replaced by IPV in India as well as in the world. So the vaccine induced cases are of 2 types. One is VAP, other one is VDPV. VAP is vaccine associated paralytic poliomyelitis. VDPV is vaccine derived poliovirus. So VAP are the cases, VDPV are the strains. Yes or no? VAP occurs due to OPV like strain. OPV like strain they differ from OPV by less than 1% genetic difference. They say that you give OPV to the most of the children. In some children, OPV will undergo a mutation and will become OPV like strain. Those OPV like strain where the mutation is less than 1% of the genetic chains, such OPV like strain can cause VAP. However, because the genetic difference is not much, so if you have a high population immunity, like for example in India OPV is widespread, everybody, all the children will receive OPV. So most of the Indians will have high population immunity against OPV, will have antibodies against OPV. So the genetic difference is not much, only less than 1%. So if the community has high population immunity against OPV, our antibody titer is more against OPV, then it will prevent the circulation in the community. So OPV like strains, they usually do not circulate in the community. Then who will get VAP? VAP occurs only to the OPV recipient, the recipient to whom you are given OPV. If that OPV undergoes mutation and will become OPV like strain, then that can cause VAP to that particular child or to their immediate contact. Like with the children to whom the child is playing, those immediate surrounding children only will get OPV like strain via the fecal-oral spread, but it doesn't circulate in the community. Long distance it cannot go because high population immunity will prevent. Clear? And of course VAP, the most common serotype is type 3 followed by 2 followed by 1. This is the sequence of VAP. Type 3 is the most common cause of VAP, followed by 2 followed by 1. And the occurrence of VAP is 4 cases per 1 crore of OPV dose. 4 cases per 1 crore of OPV dose. That means the cases are more or less. The cases are less when you have more number of natural cases, but the situation like this, when there is no natural cases now in the world, even few VAP cases also will make difference or not. Yes, that is why there is a high possibility of switchover of OPV to IPV. So this is about VAP. In contrast, what is VDPV? VDPV is vaccine derived poliovirus, and these viruses, they differ from OPV by more than 1% genetic difference. The genetic difference is more than 1%. The genetic difference is more than 1%. That is why they say that population immunity do not prevent the spread of the vaccine virus. The VDPV viruses, they can go to the distant sites also, because the population immunity cannot prevent the state. So that is why it can go to the distant places, and they say that it will be residing in the environment, and sometimes they can cause infection also. Mainly it resides in the distant environment, sometimes it can cause infection also. That is why the occurrence we don't know. How much of VAP cases, how much of VDPV cases, it is very difficult to assess. Very difficult to assess the number of VDPV cases. because it may be there in the environment also. The most common type is type 2. Type 2 is responsible for most of the VDPP cases, but please remember in 2015 the most common cause of VDPP was type 1. So if they ask for 2015, you can write type 1, but otherwise the most common cause of VDPP is type 2. Okay, and there are 3 types of VDPP: circulating VDPP, immunodeficiency associated VDPP, and ambiguous VDPP. This was asked in AIMS 2015, which is not a VDPP. C VDPP, I VDPP, A VDPP, M VDPP was there. Answer was M VDPP. So you just remember the expansion: C for circulating VDPP, I for immunodeficiency associated VDPP, A for ambiguous VDPP strains. Okay, so this is all about the vaccine cases, very important for exam. Now I will tell you the polio situation in world. This is also important for exam. Polio situation in world. What are the countries the polio is endemic now? PAN countries. True or false? What is PAN country? Pakistan, Afghanistan. That's all. Polio is endemic only in Pakistan and Afghanistan. Nigeria is now polio free. Okay, so Pakistan and Afghanistan only are the 2 countries. Till January 2016, they say that I will tell you the 2015 data. Your 2016 data, anyway it will vary from month to month. 2015, the whole year, they say that only 71 natural cases. In contrast to 2014, which has witnessed 359 cases. I am talking about natural cases. So 2015, the cases were much more reduced. Okay, and of course Pakistan accounted for maximum cases. Okay, India has been reported as polio free since 2014. The last case was reported in January 2011 in India. Okay, January 2011, and 2015 at the same time you can remember 71 natural cases and 21 CVDPP cases, circulating VDPP cases were reported in the world. The entire world has reported 71 natural cases and 21 VDPP cases. Okay, so this is about the polio situation. Now I will tell you about end game strategy. End game strategy is a strategy which was put forth for the eradication of polio. What are the principles to be followed? What are the strategies to be followed when the polio is going to be eradicated? There are 4 important principles of end game strategy. First is interruption of polio virus transmission. The polio virus transmission has to be interrupted. Then switch over of an only OPV schedule to a OPV IPV schedule, and gradually you will have a only IPV schedule. So this switchover is important. Third is containment. They say that containment of poliovirus from all resources, including lab. This is important or not? You will tell that the polio is eradicated, but there will be some research going on poliovirus in certain hospitals or in certain institutes, labs. After some time, the research strains will be spread in the community. So it cannot be allowed. In smallpox, that was the reason why one outbreak had happened. So now they say that we cannot allow that containment of the vaccine virus or the polio wild virus from all the resources, including the laboratory. And the last is, once the polio is eradicated, what you are going to do with the infrastructure? Polio eradication program is one of the richest program of the world. So many millions, trillions of money has been involved, and so much of infrastructure, so much of manpower has been used. So what you are going to do with that infrastructure? So they say that it is called as polio legacy plan. Polio legacy plan is the infrastructure has to be shifted to other healthcare program in a planned manner. Okay, it has to be shifted to other healthcare program in a planned manner. I mean, that planning also has to be done from the beginning only. This endgame strategy is applied for 2013 to it is applied from 2013 to 2018. This is the period where the endgame strategy is applicable, and they say that from the beginning only you have to do the planning of diversing the fund for other healthcare programs. Okay, so this is all about polio. Now I will tell you one important thing. They ask that what criteria has been followed now. They say that now there is a, in 2016 Government of India has planned that we have to start using IPV and bivalent OPV. So what protocol has been designed is, IPV has been introduced from November 2015, and one more thing is bivalent OPV. This will be introduced from April 2016 onwards. Okay, and what is the exact plan, how they are going to introduce? That exact plan is, they say that the from under immunization, under national immunization schedule, they are going to introduce 1 dose of IPV. And this 1 dose of IPV will be an extra dose given over and above the trivalent OPV. This 1 dose of IPV is an extra dose given over and above trivalent OPV. And the trivalent OPV to bivalent OPV, whichever is like this, from April 2016, I mean exactly if you tell, the switchover will happen in April, but they say that the November 15 to April 2016, this is the period. They say that the 3 doses of trivalent OPV will be going on, plus an extra dose of IPV. This is given at 14th week, that is the last dose of trivalent OPV. Along with that you give an extra dose of IPV. So this criteria has been followed from November 15 to April 2016. Then April 2016 onwards, you can say that March, this will be March 2016. So from April 2016 onwards, the bivalent OPV 3 doses plus 1 dose of IPV again at 14th week. So this is how the plan is designed in India, and this is again a very important aspect. Recently it has been used, so there is every chance that they can ask in the exam. Okay, so this is all about poliovirus. So let us now discuss about rabies. Rabies is again a bullet shaped virus. It contains negative sense single stranded RNA and it is bullet shaped, and as far as the mode of transmission is concerned, of course bite, the most common mode is dog bite, but apart from, they say that lick on abrasion can also transmit. Other animal bite, other wild as well as domestic animal bite, most of the wild and domestic animal bite also can transmit rabies. So unlike we think only dog, not dog, even monkeys and other domestic animal, wild animals like wolf, jackal, all this also can transmit. If they ask except which animal bite do not transmit or less infectious, then the answer is rodent as well as human bite. Human bite also we have not got any case that is transmitted by human bite, but the possibility cannot be ruled out, but the cases have not been reported. Is it only bite? Apart from bite, as I told you, lick on abrasions can be transmitted. Corneal transplant, and inhalational mode, and this is possible through bat, especially in South America. The rabies can be transmitted from bats by inhalational mode. This is quite important in South America. Okay, so this is all about mode of transmission of rabies, and the route of spread. The spread, they say that at the local site the virus replicate first in the muscle, and from muscle it enters to the peripheral motor nerves. From motor nerves it goes to spinal cord, then CNS, and CNS the target site is hippocampus and cerebellum. This is the target site of rabies in CNS. Then again from CNS the virus can travel along with sensory nerve and autonomous nerve to various organs. If they ask the most important specimen, which organ the specimen is, I mean the most widely used or most ideal specimen, if they ask, can you tell? They say that hair follicle from the nape of the neck. Hair follicle from the nape of the neck is the most important specimen. Okay. So, and please remember, all this migration, it occurs at a speed of 250 millimeter per day. This is the speed of rabies virus. At this speed it travels the entire pathway. That is why the incubation period also is variable. They say that 1 to 3 months is the incubation period, and incubation period is shorter for wherever the distance is less, like for example in children, upper limb bite, and dwarf short individual. In all these cases the incubation period is shorter because the distance to travel to CNS is less. Okay. Regarding the clinical feature is concerned, there are two kind of rabies: furious rabies and dumb rabies. Furious rabies is otherwise called as encephalitic rabies, and the other one is dumb rabies or paralytic rabies. Furious rabies or encephalitic rabies, it is the most common form, whereas the dumb rabies is only 20% of cases, and the paralytic or the dumb rabies occurs when the individual is partially vaccinated. In such case the dumb rabies takes place. If the individual is unvaccinated, then he will develop furious or encephalitic rabies, and this is characterized by hydrophobia, aerophobia, hyperexcitability, hypersexuability, increase talkative. The person will start shouting everyone. Shouting everyone. If the person always shout, then it is not a rabies case. All of a sudden the patient will start shouting everyone. Apart from that, ANS manifestation. There are various ANS manifestation like sweating, okay, goose flesh, goose skin, sweating, all this hyper salivation. Okay, so all these are the various ANS manifestation. Okay. Dumb rabies is characterized by, why it is called a dumb rabies? Because there is no hydrophobia. Unlike the furious rabies, here there is no hydrophobia. Here what will be there is fever, fasciculation, percussion edema, and also paralytic features, will be there. So all these are the manifestations of dumb rabies or paralytic rabies. Okay, so this is all about the clinical manifestation. Then let us now discuss on the lab diagnosis. Lab diagnosis, rabies, always there is a ante-mortem diagnosis, there is a post-mortem diagnosis. Ante-mortem diagnosis, mainly it is done by direct immunofluorescence test to detect the antigens in, which is the most common specimen I told you, hair follicle in the nape of the neck. Apart from that, antibody detection in serum as well as in CSF. The most consistent diagnosis, the best method, the most sensitive and specific method is RNA detection by doing a reverse transcriptase PCR. It is the most sensitive and specific method. Okay, so these are the ante-mortem diagnosis of rabies. Post-mortem diagnosis. Post-mortem diagnosis is done by Negri body detection. They say that it is pathognomic of rabies. Most common site being hippocampus and cerebellum. However, it may be absent in 20% cases. Always negri body may not be present, and there is a special staining technique called a Siller technique, which is employed to stain the negri bodies. Okay, so this is all about negri body, which is pathognomic of rabies. Then prevention. Let us now discuss the vaccination of rabies. Vaccines are broadly categorized into neural and non-neural. Neural vaccines are outdated. They are encephalitoogenic, hence they are not used. Example of neural vaccines which are outdated now are sample vaccine, BPL vaccine and infant mouse brain vaccine. All the three vaccines are outdated now. Non-neural vaccines, the examples are, yes, purified virocell vaccine, purified chick embryo cell vaccine. All these are cell line derived. The non-neural vaccines are cell line derived vaccine. Purified virocell vaccine, purified chick embryo cell vaccine and human diploid cell vaccine. Human diploid cell vaccine. So, how to give these vaccines? They say that the non-neural vaccines are given under this criteria: post-exposure prophylaxis. Post-exposure prophylaxis, total 6 doses, 5 dose plus 1 booster, given at day 0, 3, 7, 14, 28 and booster at 90 days. You can also give as pre-exposure prophylaxis. Pre-exposure prophylaxis is given to all or high risk. Only high risk group. High risk group like animal handlers, butchers, abattoirs. So any people, the group of people who handle the animals, veterinary doctors. So those group of people you can give a pre-exposure prophylaxis, and it is given as 3 doses at day 0, 7 and 21 days. One more schedule is there: post exposure prophylaxis in previously vaccinated people. That is the people who keep on getting dog bites. So for them the vaccination is given or not, that depends upon 2 criteria. They say that if it is less severe bite and if the antibody titer is less than 0.5, more than 0.5, then 2 doses are given, 0 and 3. If it is a severe bite and the antibody titer is less than 0.5, then 3 doses are given as 0, 3 and 7 dose. So this is post exposure prophylaxis in previously vaccinated individuals. Okay, so all this they usually ask. So you have to remember the schedule of rabies vaccine. The risk categories they sometimes ask. The risk category. They say that there are 3 risk categories. Category 1 is considered as no risk, and this include touching or feeding animal, or even if the lick is there on intact skin. This is called as category 1, no risk, hence nothing is given, no need to give anything. Category 2, minimal risk, and here the examples are, there are various examples like minor scratches, or abrasions without bleeding, abrasions without bleeding, or nibbling of uncovered area, just the nibbling of uncovered skin. So, because of minor exposure, here the guideline says is only post exposure prophylaxis is enough, vaccine is 6 doses is enough, there is no need of immunoglobulin. Category 3 is the most severe category. This includes abrasion with bleeding, leak on broken skin, or leak on mucosa, or they say that wild animal bite, wild animal or bat bite, all these are considered as severe bite, and they say that here the vaccine plus immunoglobulin is given, vaccine plus immunoglobulin. And in this context I want to tell that immunoglobulin is, I mean of course human rabies immunoglobulin is given as 20 international unit per kg and maximum given locally, rest given intramuscularly, maximum given locally and rest is given IM. It was half before, 50% locally, 50% IM. Now they have changed the guideline, maximum given locally and rest is given IM. Okay, and please remember, never suture the wound. Stitching is contraindicated because it will aggravate the spread of the virus. Never, you can apply soap and water. Soap and water can be applied to the bite wound, but never suture the wound. This is again a condition you have to remember. Okay, so that finishes the chapter. Hepatitis viruses are there. The hepatitis viruses are classified from A to E and G. Okay, there is no hepatitis F virus, A to E and G. Very frequently they ask the differences between hepatitis viruses. Here I can easily classify into two hepatitis virus group, B, C, D and A and E, because there are many resemblance which you can easily remember. A and E hepatitis virus, they are fecal-oral transmission, transmitted by fecal-orally. Okay, and there is only acute stage, there is no chronic infection, as well as there is no carrier for them. There is no chronicity and there is no carrier, and they have a abrupt onset, and as a result incubation period is short, around 15 to 45 days. Incubation period is short, which is around 15 to 45 days. Of course, there is no oncogenicity. Oncogenicity is nil. Okay, and they say that these two viruses are non-enveloped viruses also. Non-enveloped viruses also. Okay, so these are the common features of hepatitis A and E. In contrast, B, C, D, they are transmitted by sexual mode, vertical mode and via blood. Okay, sexual, vertical and via blood, mainly blood. This is the most common mode of transmission. They are enveloped viruses and they have both chronic stage as well as they have carriers. They have insidious onset, slow onset, incubation period is longer, maybe around 30 to 180 days, longer incubation period. They are oncogenic. They are oncogenic. Okay. So, this is how the differences between various hepatitis viruses are there. And regarding the fulminant hepatitis, all can cause fulminant hepatitis, but it is maximum in hepatitis D virus. Why? Because it is D is a double virus, right? It always infects along with hepatitis B. That is why the fulminant hepatitis chance is maximum. And the fulminant hepatitis in pregnancy, the most common is hepatitis E virus. Hepatitis E virus is the most common cause of hepatitis in pregnancy. Okay, so this is all about hepatitis viruses. Differences. Let us now discuss lab diagnosis. Lab diagnosis of hepatitis A and E. They can cause acute infection only. So, IgM antibody detection indicates acute infection. If you detect IgG, it indicates recovery because there is no chronic stage. So, if IgG is there, it indicates recovery. Apart from that, the viral particles can be detected by electron microscopy. Viral particle in stool can be detected by electron microscopy. Okay, so this is about hepatitis A and E diagnosis. Diagnosis of hepatitis B, very important. Hepatitis B virus, there are 3 antigens, 3 antibodies which are important in diagnosis. The 3 antigens are HBsAg antigen, HBcAg antigen and HBeAg antigen. HBsAg antigen, S for what? Surface antigen, also called as envelope antigen or Australian antigen. Okay, and they say that it is the first marker to rise, first marker to elevate. It is present throughout the course of the infection, right from incubation period to acute chronic carrier. Throughout the illness, the HBsAg antigen will be present. And of course, they say that it is a epidemiological marker. HBsAg antigen is used as a epidemiological marker, that is to calculate what? Prevalence of infection. To calculate the prevalence of infection. In contrast, the C antigen, C for what? Core antigen. It is a hidden antigen. It is a hidden non-secretory antigen. It is a hidden non-secretory antigen, hence it is never detected in blood. It is never detected in blood. However, it may be detected on hepatocyte by immunofluorescent microscopy. Though it is never detected in blood, it may be detected over the hepatocytes by by immunofluorescent microscopy. Okay. What is the third antigen? E. E for what? Many students wrongly tell E for envelope. No, envelope antigen is same as surface antigen. E is wrongly given, it is just a pre-core antigen. It is a pre-core antigen. And they say that I will tell you the interpretation of HBE as well as HBV DNA. Even HBV DNA, both the interpretation is same. The interpretation of both is they are the marker of active viral replication as well as they are the marker of high infectivity. High infectivity means what? The transmission is maximum. But at this context I want to add one more point. HBsAg appearance indicate onset of infectivity. HBsAg appearance indicates onset of infectivity, that is transmission starts, whereas transmission maximum will be denoted by HBeAg as well as HBV DNA. These two marker indicates transmission is maximum. Okay. And one more thing, though transmission is maximum and high infectivity, but it could be any stage, it could be acute, chronic or a carrier. It cannot differentiate acute and chronic. It may be anything. The message what it gives is high infectivity and active viral replication. It could be acute active hepatitis, it could be chronic active hepatitis, or it could be a carrier which is actively replicating. Such carriers are called as super carriers. Super carriers are the carriers where the virus is highly infectious, actively replicating. Okay, so these are the three antigens and their interpretation. Similarly, there are respective three antibodies. The core antibody is the first antibody to appear. It could be two type, IgM and IgG. IgM indicates acute infection, IgG indicates chronic infection. And please remember, IgG is non-specific. Okay, following infection what you will have first? Acute stage. After the acute stage, the patient may go to recovery, the patient may go to chronic, the patient may become a carrier. In acute stage you will have IgM. From acute, whichever three conditions the patient go, either a recovery or chronic or carrier, IgM will become IgG. So IgG indicates either chronic or carrier or recovery. It is non-specific marker, it cannot differentiate what it is. What about HBe antibody? HBe antigen indicates what? Active viral replication, whereas HBe antibody indicates low infectivity, less transmission. Less transmission means what? Transmission is there or not there? Transmission is there but lower rate. Which marker indicates no transmission? Zero transmission. Which marker indicates onset of transmission? So the moment S antigen disappears and gets replaced by S antibody, it indicates non-infectivity. And HBs antibodies are also the marker of post vaccination, and they are also the marker of recovery. Please remember, which marker is present throughout the course of the illness, right from incubation period, acute, chronic, carrier, everywhere HBsAg antigen is there. The moment HBs antigen disappears and gets replaced by HBs antibody, it indicates the patient has recovered. It is a marker of recovery. Okay, so these are the various antigens and antibodies and their interpretation, what you have to remember for exam. Fine. So now we will discuss the diagnosis of hepatitis C. Hepatitis C basically stays as a chronic infection. It shows maximum chronicity. among all the hepatitis viruses. Okay. So, it is diagnosed by usually a IgG ELISA. You can do a third generation ELISA to detect IgG antibodies. Apart from that, you can do HCV RNA detection by doing a reverse transcriptase PCR also. Okay, so, these are the methods to detect the hepatitis C virus. They say there is the most common cause of post transfusion hepatitis. Most common cause of post transfusion hepatitis. Fine. Then hepatitis D. D for what? D for defective. Hepatitis D virus is defective, it is a dependovirus. Why dependo? It is also called as delta virus. Why dependo? It depends on what? It always depends on hepatitis B virus. They say that hepatitis D virus is always in association with hepatitis B, and the association is of two types: co-infection and superinfection. They say that hepatitis D and B is always associated, always it requires hepatitis B virus for replication, and the association is of two types called as co-infection and superinfection, which is simultaneous, which is one after the other. Co-infection is simultaneous, that is, in a hepatocyte simultaneously hepatitis B and hepatitis D infection occurs. Both the infection occurs as acute hepatitis. Both the infection occurs as acute hepatitis. So, what is the marker of acute hepatitis B infection? IgM HBC. What is the marker of acute hepatitis D? Again IgM hepatitis D virus. Whereas superinfection, what is already there? Superinfection is one after the other. So, first what is already there inside? Hepatitis B virus is already sitting inside as a chronic infection. What is acutely infecting is hepatitis D. So, in this case hepatitis D, of course IgM hepatitis D will be there, but hepatitis B the marker is IgG HBC. So, please remember the marker to differentiate co-infection and superinfection is HBC antibody. If HBC antibody is IgM, co-infection; if it is IgG, superinfection. Okay, fine. And can you tell me which is the most common cause of hepatitis in India? A, B, C, D, E. Hepatitis E virus. Please remember, most common cause of hepatitis in India. Okay, so this is the nutshell of hepatitis viruses. Okay, this is one of the important virus you have to remember for exam. So, let us now discuss next topic, that is HIV. Human immunodeficiency virus. Okay. HIV virus, they say that it has two copies of what? Single stranded RNA, Along with that, it has got certain enzymes. Those enzymes are, what are the enzymes HIV has? Reverse transcriptase, integrase and protease, which is surrounded by the capsid or the core antigen or the P24 antigen. Okay. The capsid is surrounded by matrix or the shell antigen. This is the matrix or the shell antigen, and this is further surrounded by outer covering, that is envelope. An envelope, this is the lipid part of the envelope in which the proteins are embedded. The proteins are called as glycoprotein. The pedicle is GP41, or which is also called as the fusion protein, whereas the knob is GP120. So, this is how the structure of HIV you need to remember, and please remember it is a GP120 that binds to the human CD4 molecules. Okay. So, let me tell you the binding properly. The receptor interaction is like this. GP120 of HIV binds to CD4 molecules. The CD4 molecule will be there in T helper cell, and they also be there in macrophages and dendritic cells, especially macrophages. And we need a co-receptor also. This is the main receptor for HIV. Apart from that, the GP120 also binds to co-receptor. The co-receptor is CXCR4 molecule for T helper cell, whereas CCR5 molecule is the co-receptor for macrophages. So, both main receptor as well as co-receptors are important for initiation of infection. Once this binding takes place, the next step is GP41. This is the fusion protein. So, what it does is, so once the GP120 of HIV binds to the receptors and co-receptor of human cell, once this binding takes place, next is GP41, which is the fusion protein. What it does is, it gets unfolded and it tries to fuse the HIV with the membrane of CD4 cell. Once this fusion takes place, whatever is there inside HIV, that gets released into the cytoplasm. Whatever is there inside means 2 strands of RNA plus the enzymes, they will be released into the cytoplasm of the T cell. And next step is the single stranded RNA. With the help of reverse transcriptase enzyme, it becomes single stranded DNA. The single stranded DNA will become double stranded DNA, and double stranded DNA, it goes to the nucleus and it gets integrate with the host chromosome, followed by it undergoes a period of latency. Okay, so this is what you need to remember, the replication of HIV inside the cell. And there is a mutation called as delta 32 mutation. The delta 32 mutation is a specialized mutation, occurs on CCR5 molecule, and this is seen in 5 to 10% of European people. And these 5 to 10% of European people are considered as the luckiest people of the world, because they will never get HIV infection because of the mutation in CCR molecule called as delta 32 mutation. Those people are resistant to HIV infection. Okay. So this is all about then the transmission. Transmission, the most common mode of transmission is sexual, whereas maximum risk blood transfusion. Okay. In sexual, again heterosexual most common, but homosexual increased risk. Okay. So in world, the most common transmission in the decreasing order, sexual is the most common mode. As I told you, vaginal intercourse is more common than anal. I am telling you the most common mode of transmission, not the risk. So vaginal intercourse is more common than anal intercourse, followed by parenteral. I mean, one second, before parenteral, the next common is mother to child, vertical transmission. Then IV drug abusers. Then comes blood transfusion. Then comes the last is needle stick injury. The last is a needle stick injury. So this sequence you need to remember, because they ask very frequently. If they ask the risk of transmission, the risk of transmission is highest is blood transfusion, followed by again vertical transmission, then injection IV drug abuser, then needle stick injury, then sexual. In sexual again more is homosexual than heterosexual. Okay, so this sequence, both this sequence are extremely important. Okay, especially in APBG, when they have some 20-30 questions, they will join together to form one MCQ. So this kind of questions they can easily ask. Okay, so this is the sequence you need to remember. Genotype distribution. This is one more aspect of HIV you need to remember. You know that HIV has got two subtype 1 and 2. I mean two types 1 and 2. Type 1 has further been divided to clades. Clades are from A to J. Clade, CLADE. Okay, so let me tell in detail so that you will understand. So two types are there, 1 and 2. Type 1 has been divided into into three groups: group M, group N and group O. Group N is the most common group, which is further divided into clades or subgroups. Clades are total 10 clades are there from A to J. From A to J. Okay. And here they say that the genotype distribution is clade A. Clades are also called as subtype. Okay. Subtype or clade A is common only in West Africa, whereas B is common in Europe, and subtype C is the most common form in the world, and it is also the most common form in India. C. Worldwide 47% cases are due to C. 47% of total HIV cases in the world are due to C. Okay. And they say that in Western Africa is the only place where all HIV subtypes are prevalent. Especially there is a place called as Cameroon. In the Cameroon, which is there in the Western Africa, where all HIV clades are types and subtypes are available. Okay, so this is a genotypic distribution of HIV which they may ask in the exam. Okay, so this is all about. Then I can tell you the CD4 count and what opportunistic infection. When the CD4 count is 400, you may have Kaposi sarcoma. 350 for Mycobacterium tuberculosis infection. 300 hairy cell leukoplakia can take place. 200 for pneumocystis infection. This is important. Pneumocystis jirovecii pneumonia occurs in 200. 50 for Mycobacterium avium complex, cytomegalovirus, okay, as well as Cryptosporidium infection. Okay, so 50 is the cutoff below which Mycobacterium avium complex, cytomegalovirus, all this infection can take place. Okay, so the opportunistic infection and HIV relationship is, CD4 count relationship is again important for exam. Okay, so let us now discuss about the epidemiological aspect. What is the prevalence of HIV in the world? HIV prevalence in the world is around 0.8% in adult, and maximum cases of HIV in the world, they reside in sub-Saharan Africa. One in 20 adult, this is the ratio, my God, in sub-Saharan Africa. Whereas as far as India is concerned, Indian situation is slightly better. The prevalence is 0.27%. As far as absolute number of people living with HIV AIDS is concerned, the worst affected state is Andhra Pradesh, followed by Maharashtra. I am telling undivided Andhra Pradesh is the worst affected state, followed by Maharashtra. This is about the absolute number of people living with HIV AIDS is concerned. But as far as the prevalence is concerned, that is the density. Prevalence means what? The total number of population, the total number of HIV case per 1000 population. If that is concerned, then the maximum number of cases will be northeast. Northeast like Nagaland, Mijopur, Mizoram, Manipur, all these are the places where prevalence is more, and they say that the Nagaland has a prevalence of 0.88, 0.88, slightly more than world global prevalence. Okay, so this is what you need to remember. Okay, now my domain, laboratory diagnosis. Laboratory diagnosis of HIV, again broadly you can categorize into the specific tests and immunological tests. Non-specific immunological tests such as low CD4 count, altered CD4 to CD8 ratio, presence of abnormal immunoglobulin like neopterin and beta 2 macroglobulin. So, this is because of polyclonal B cell activation. This is because of polyclonal B cell activation, you will have neopterin and beta 2 macroglobulin. So, these are immunological non-specific tests. Specific test is concerned, again the test used for screening, the test used for supplementary, and the test used for confirmation. Screening, always the tests are antibody detection tests, and usually ELISA and the rapid test are used for screening. ELISA and rapid test are done for screening. Supplementary tests are also antibody detection tests, but with more specificity. You know that ELISA and rapid tests are having more sensitive, they are highly sensitive tests, whereas supplementary tests are also antibody detection tests, but they are having more specificity. These antibody detection tests, example like Western blot, line immunoassay, RIPA, that is radio immunoprecipitation assay, radio immunoprecipitation assay, RIPA, and of course even your immunofluorescence assay. All these are considered as antibody detection tests, but they are more specific, so they are used for supplementary tests. In HIV, the antibody detection specific tests, they are not called as confirmatory tests, because usually antibody detection cannot be used for confirmation. Like for the confirmation, always PCR or antigen detection has a better value. So, confirmation is done by either by P24 antigen detection or by reverse transcriptase PCR to detect the RNA, or by viral culture. The culture method is called as co-cultivation. Co-cultivation. All these are done for confirmation. In that, the best is reverse transcriptase. The RNA detection is considered as the best confirmatory method for HIV diagnosis. Okay, I will tell you something about NACO strategy also. NACO is National AIDS Control Organization in India, and NACO strategy says, the NACO says that though RNA detection and Western blot, all these are better for specific method for confirmation, but in Indian scenario where we don't have resources, not possible to do all these tests, and HIV diagnosis cannot be done only by one test. You have to do a confirmation, because it is a very sensitive issue. It is one of the tests, unless it is confirmed by a second or third test, we do not report. So, in this situation, the NACO has given the strategy that the screening tests can be repeated again and again for confirmation, and this is done by using a different, they say that the second and third screening tests, all the three screening tests, 1, 2, 3, if you are using 3 screening tests, all the 3 screening tests should be different in principle, and or they should use different antigens to detect antibody. Okay, so this is the principle they have followed. Accordingly, there are three strategies. Accordingly, there are three NACO strategy. Strategy 1, only one test is done. If it is positive, discard the sample. Negative, use the sample. It is done for blood bank. In blood bank, you know that whenever any blood unit is received, they do a HIV test. If it is positive, they discard the unit. If it is negative, they use. Never inform the patient. If you are informing patient, you have to confirm. Only one test, you cannot inform the patient. Strategy 2 is done for two purposes. For epidemiological purpose, to calculate the prevalence of infection. There is a new state, like for example now Telangana. It's a new state, we don't know the prevalence of infection. So to how to know the prevalence, we have to do strategy 2. Two tests you have to follow. Otherwise, diagnosis of HIV in symptomatic patient, full blown symptom will be there. In this case, in these two situations, test 1 is done. If positive, do test 2. If both positive, then report. Strategy 3 is the most commonly used strategy. It is done for asymptomatic individual, and here test 1, test 2, test 3. If all are positive, then only you have to report. What about for equivocal cases? There may be equivocal cases. Equivocal cases means mixed report. There may be equivocal cases, especially when you are doing strategy 2 and 3. First test will be positive, second and third will be negative, like that mixed report will be there. In this situation alone, you have to do a RNA PCR, or you can do a Western blot in the reference center. In the reference center. Okay, so this is all about the HIV NACO strategy. Then how to diagnose HIV in window period? What do you mean by window period? Window period is a time interval between infection till first appearance of antibody. This is the interval when the antibodies, all antibody tests will be negative. So here the best method is, you have to do a RNA PCR. This is the best method. Otherwise, you have to do a P24 antigen detection. They say that approximately the window period in India is around 3 to 12 weeks. This is the interval between infection and appearance of first antibody. This is the most approximate duration of window period in India. If you do the RNA PCR, then the window period can be decreased to as low as 12th day. Okay, P24 detection you can detect in 1 to 2 weeks, maybe in average of 16 days. So this is how you can detect the diagnosis of HIV in a window period. How to do prognosis of treatment? Treatment prognosis. They say that the most common method followed for the prognosis of treatment is CD4 T cell count. This is done by a method called as flow cytometry. But if they ask which is the best method for prognosis, HIV RNA load monitoring by real time PCR. This is the best method for prognosis of HIV. Treatment response always is measured along with, in parallel with RNA load. Other methods like P24 antigen detection, abnormal immunoglobulin like neopterin and beta 2 macroglobulin. These are also measured for prognosis. Okay. How to diagnose HIV in pediatric individual? Pediatric individual, as I told you that the screening tests, all the screening tests like ELISA, rapid tests, most of the tests they detect IgG antibody. Because they detect IgG antibodies, you cannot use the screening test for diagnosis of pediatric individuals up to 18 months. They say that the IgG antibodies you can do only after 18 months. So below 18 months, because of the risk of maternal transfer of IgG antibody, so you cannot distinguish it is a maternal IgG or it is a baby IgG antibody. So before 18 months, the routine ELISA or any screening test is not done. The best method to diagnose of HIV in a pediatric individual is by doing HIV DNA detection. What is HIV DNA? HIV DNA means what? It is a cell associated DNA. HIV inside the T cell receives RNA or DNA virus? DNA. So that DNA you are going to detect. Other than that, you can also go for P24 antigen detection, but the best is HIV DNA detection. Okay. HIV RNA detection also you can do, but the best is DNA detection. Okay. So this is all about diagnosis of HIV. Okay, so in this particular topic we will discuss miscellaneous viruses like hantavirus, Ebola virus, coronaviruses, the variant of coronaviruses like SARS and MERS coronavirus. So rodent borne viruses, the first category of miscellaneous viruses, rodent borne viruses. Under this, hantavirus and arenavirus are the two major group. Hantavirus, the transmission is, it is transmitted by inhalation of aerosols containing rodent excreta. This is again a very frequently asked MCQ. It is in Anand Narayan it is wrongly given under arbovirus. Please remember, it is not arbovirus because it is not arthropod borne. It is transmitted by aerosol transmission. So the aerosol containing rodent excreta. Aerosol containing rodent excreta. Okay. So hantavirus can cause two broad category of manifestation: hanta fever with pulmonary and hanta fever with renal. So the first category is hanta fever with renal syndrome, and the second manifestation is hantavirus, hanta pulmonary syndrome. Okay, so these are the two important manifestations of hantavirus. Coming to arenavirus, arenavirus broadly divided into New World and Old World. The Old World virus is very important. Examples are Lassa virus, Lassa fever viruses. And LCM virus, that is lymphocytic choriomeningitis virus. LCM virus. So these two are under old world virus, whereas new world viruses are the agent of South American hemorrhagic fever. All the new world viruses, they cause South American hemorrhagic fever. Okay. Example, there are various viruses you can read from book. Junin virus, Machupo virus, like that there are so many rare viruses, but all together collectively they can cause South American hemorrhagic fever. So this is all about rodent borne viruses. Then we can discuss about Ebola virus. Ebola again is very important as far as exam point of view, because it has caused a major threat in 2014. So filoviruses contains two important viruses, Ebola and Marburg, and both these viruses are filamentous virus. Both these viruses are filamentous, like this, they are filamentous in shape. Okay, and both these viruses are highly fatal, they cause extremely fatal hemorrhagic fever. Okay, and coming to the Ebola virus proper, in 2014 it has caused a global threat. Can you tell me which is the country, which were the country who got maximum number of cases? Maximum number of cases were reported from 3 African countries. What are they? Guinea, Liberia and Sierra Leone. So these are the 3 African cases who got the maximum, African countries who got the maximum number of cases. This is the main endemic focus of Ebola virus in 2014. Coming to the species, they say that it has got 5 important species, and the Zaire species was responsible for 2014 outbreaks. The 2014 outbreak was due to Zaire species. And why it is named like Ebola virus? It is named after Ebola river in Africa in 1976. It is named after Ebola river. Okay, so these are the some of the MCQs what they can ask. The largest outbreak, as I told, it has occurred in 2014. And number of cases as of January 2016, this particular outbreak has caused around 28,000 cases with 11,000 deaths. That is what I told you little bit earlier. The mortality is, see how much, maybe around 40%. So that is why they say that it is having the highest mortality among the hemorrhagic viruses, among the hemorrhagic fever producing viruses. This particular virus has highest mortality. Okay. Of course, India no cases has been reported yet. Okay. So regarding the transmission, direct close contact with the secretion or maybe organ or other body fluid of the infected animal or human. So there will be so many options in the MCQ, ingestion, inhalation. No, the most common mode of transmission is direct close contact. Direct contact is the most common mode of transmission. Sexual transmission is doubtful. They say that we have detected Ebola virus in semen, but sexual transmission is doubtful. It has not been documented yet. Okay, clinically, as I told you, it is nothing but it is a viral hemorrhagic fever. It will resemble almost any viral hemorrhagic fever, but only thing is the mortality is maximum. Okay, there is no treatment available. Lab diagnosis wise, you can detect the RNA detection, antibody detection. Okay, so all these are various laboratory diagnosis tool. Isolation also is done, but because of the risk of exposure, isolation is not recommended. It can cause laboratory acquired infection, hence isolation is not recommended. Vero cell lines of course can be used. Treatment only supportive. And in India, though no cases are reported, they say that any person presenting with acute onset of fever, so any fever patient coming from the 3 African country, coming from the endemic African country to India, the guideline they have said that 21 days they have to undergo quarantine. So in India, though there is no case, but the guideline what they have put forward is any febrile case coming from these 3 endemic African countries, that is Guinea, Liberia and Sierra Leone, they have to be quarantined for a minimum period of 21 days. Okay, so this is all about Ebola virus. Then bit about coronavirus. Coronavirus, they are petal or club shaped. Petal or club shaped spikes will be there. They say that from the virus, the envelope, of course they are envelope viruses. The envelope viruses, the protein spikes are petal shaped or club shaped. Okay, so the 2 important coronaviruses are, which has caused a global threat, is one is SARS coronavirus. It has caused a global threat in 2003, and in 2012 MERS coronavirus, that is Middle East respiratory syndrome coronavirus. SARS coronavirus is severe acute respiratory syndrome coronavirus. So these are the 2 important viruses, SARS coronavirus and Middle East respiratory syndrome coronavirus. The Middle East respiratory coronavirus was mainly endemic in Saudi Arabia. Okay, that's all.